Good morning, good afternoon, good evening. This is Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in the United States. It's my pleasure to be welcoming you and to be joining you at the second webinar of our efforts to build a community of practice supporting the introduction and scale up of hepatitis B birth dose in the African region. It's really great to have this discussion, and I look forward to all the presentations from a variety of countries as they describe where they are in the process of introducing and then scaling up hepatitis B birth dose vaccination. I want to thank the organizers of the webinar today, particularly Dr. Rania Toomey of the US CDC and Dr. Julian Gabore of the Afro region of WHO, and as well as some of my colleagues here at the task force who you will be meeting over the course of the webinar. Next slide, please. What we're seeking to do over this webinar is really very much in keeping with the overall mission of our coalition, is building a community of practice, bringing all the different persons and organizations with their expertise and capacity to come together to address the implementation of a critical implementation tool or strategy that makes prevention more effective, and therefore our efforts to eliminate this life-threatening infection that currently puts 1 out of every 40 infants at risk for because of mother-to-child transmission of hepatitis B virus. And in this community of practice, we really seek to elevate where everybody is in this work so we can begin to share information, develop peer-to-peer collaboration so people can begin to learn from each other. We can identify the critical gaps that we can all work together to help each other address and really direct our technical assistance to where it's needed most. And then through all of those efforts, marshal the resources to be successful in our efforts to introduce this vaccine to protect the health of newborns and to scale it up to a coverage where it has the maximum public health impact. And then we can then merge it with other strategies that truly make elimination possible, including the maternal testing for hepatitis B infection, and then the additional strategies to further protect those infants who we know are being exposed to hepatitis B virus. Next slide, please. This is the overall goal, as I've mentioned, developing a community of practice. And when I repeat that because it's very important, and I strongly encourage everyone to speak up either in the chat as people are talking, ask questions, begin to exchange ideas and thoughts and questions. We'll do our best to bring those up as part of our discussion. So we really, truly are learning from each other. And then in our first webinar, which we had about 4 to 6 weeks ago, we got the organizations describing from around the world actually what are being done with their partners in Africa to help scale up hepatitis B birth dose and related strategies. Here today, we're going to be beginning to learn from countries about the status of their program and the progress toward hepatitis B birth dose implementation. This will be followed by a meeting of the technical advisory groups that develop policies for immunizations known as NITAGs. And then we'll have a webinar later in the summer to bring all of the different thoughts and proposals together. And I encourage all of you to remain involved in the development of this community practice. You'll be getting notices about the upcoming webinars that will be happening later in June for this to assist NITAGs develop hepatitis B birth dose policies, and then for the webinar later on in July, and then hopefully with additional opportunities later in the year. Um, Next slide, please. I'll turn it over to my colleague, Ms. Lindsay Hebert, who will orient you to the website and give you a little bit more information about the interpreters that are available, so we can all benefit from the program. Lindsay?
Good morning, everyone, or good afternoon as well, and thank you for being with us. Just want to make you aware that we do have interpretation available, both in French and Portuguese. Many of you are probably used to Zoom, but if this is your first time, to enable that interpretation, you would go to the globe or world symbol at the very bottom of your screen, and there you will see the options for either French or Portuguese. We do expect to have one live French presentation, and then that will be interpreted to English simultaneous towards the end of the program today. And to all our speakers, which most of the presentations have been recorded, but if you do speak up in the discussion time or have any questions, please remember to speak slowly so our interpreters can catch up. And if you have any technological trouble with the interpretation, please let us know in the chat so we can help you out. Also, since this is a very large meeting, we have over 80 people on already from really all across the world. If you would please update your name in Zoom by going to participants and looking at the participant list and right-clicking over your name, you'll have an option to rename yourself. If you could please indicate your organization or your country, just to provide a little more information about where you're coming from. As many of you have done, also please feel free to introduce yourself in the chat. And this is just what it would look like. For example, I said I was from the US and I'm from the Coalition for Global Hepatitis Elimination. There is a word limit, so you do have to be a little selective in terms of what you put there. And then almost towards the end of housekeeping, we really encourage you to ask many questions and provide your perspectives in the chat. If you do have a question for a specific presenter, please indicate that so we can direct that to them. And we'll be diligently documenting all the questions and answers and be providing that to the audience following the program today. In addition to those questions and answers, all the recordings, individual presentations, and the full recording will be available on our website, and all the any resources described by any of the presenters. Will also be preparing a meeting report for each of the webinars in the series that we'll be distributing to all our community of practice. And this is just the website. We'll make sure you have this available of this meeting page where all the resources will be posted. The coalition also has a help desk that is live at all times for any questions following this meeting related to birth dose or other hepatitis elimination issues. And we've also previously prepared an evidence base on our website that has many of the core systematic reviews summarizing key challenges and data on hepatitis B birth dose, if that's of interest to you. And with that, I'll hand it back to John.
Thank you, Lindsay. It's already great to see so many greetings and hellos over in the chat. It's great to see everybody so engaged. We have a great group of 85 participants and growing. So let's get started. Just to remind you, this is our agenda. We'll have a few opening remarks from my colleague Henry here at the Coalition. We'll be hearing from Dr. Gabore from WHO AFRO, and then we'll begin to hear from countries that again are at various stages in their implementation of hepatitis B birth dose. And we will be stopping and with opportunities for questions and answers and discussion along the way. But please, no need to wait for that. Please go ahead and begin to discuss and pose questions in the chat, and that will help us have that information available when those discussion times arise. So again, look forward to the discussion. And at that point, I'll turn it over to my colleague Henry. Henry.
Thank you very much, John. I'll share my screen so that we can begin our presentation. So it's my pleasure. Can you see my screen, just to confirm?
Yes, do you want to put it in presenter view?
Yes, I will. Good. Great. Thank you so much for attending this particular meeting. And it's my pleasure to reflect back and discuss some of the things that we did discuss in the last kickoff meeting. We held our very first meeting way back in March 17 to 18. It was a 2-day meeting that was targeting partners working on hepatitis B related activities in the Africa region. And we have a presentation summarizing some of the things that we learned from this particular meeting. We had about 135 unique participants coming or participating in the 2-day meeting. And these participants were affiliated to various organizations. About a quarter of them were affiliated to MOH and NITAG. And the rest were affiliated to various partners, including technical and research partners. There was WHO representation, including funding agencies, including Gavi. Gavi was in attendance in this particular meeting. There were actually 26 countries that were represented, and those are shown in red in that map. And all the participants really came from 25 different countries from all over the world. We had about 10 presentations from various partners, including us, the Coalition for Global Hepatitis Elimination. We also had a presentation from Institute Pasteur. We had Albert Einstein, as well as University of North Carolina. We had USCDC. We had Clinton Health Access Initiative. We had WHO headquarters, as well as WHO Afro. We had Gavi, like I said, we had Africa CDC, we had Imperial College, we had partners in health, and not to mention that we also had World Health Alliance participating in this meeting. And these presentations are actually available in our website, which you can be able to access to be able to learn more about what they were. We had several key learning points from this particular presentation. We all know that we have about 257 million people living with hepatitis B virus infection. And unfortunately, 60 million of them live in Africa. That's about 6% prevalence in the general population. Hepatitis B virus infection during infancy confers the highest risk of chronic infection. About 90% of people who acquire infection within their first year of life end up developing chronic hepatitis B infection, which is associated with severe sequelae, including hepatocellular carcinoma, as well as cirrhosis, and most of them end up dying. WHO in this regard has recommended universal vaccination of babies at birth, ideally within 24 hours, and to be able to help elimination of hepatitis B, amongst other strategies. Unfortunately, in Africa, we only have 14 countries that have introduced the birth dose. And Africa has not met the 2020 interim target for global hepatitis elimination. So the global target is less than 1%, and Africa is currently at around 2.53%. Based on modeling studies, the birth dose has been shown to have the single largest incremental impact on new chronic infections. So by having birth dose, we will have a substantial decrease of chronic infection. And from the presentations, you also learned that based on community surveys, birth dose is generally well accepted amongst the community. However, to implement a successful birth dose program, you need to put into consideration cultural, political, geographic, economic, and other factors in consideration to make it a success. There was also need from the presentation to continue working with Gavi as well as other funding institutions to continue supporting birth dose introduction. So in today's meeting, we, like John has said, we are planning, and I will keep emphasizing on this because we believe that this is the best strategy to be able to have a very successful program, to build a community of practice, to share lessons learned, especially from people who have gone through the process, and that these lessons will help support the introduction of hepatitis birth dose in Africa. We also plan to discuss about the needs and priorities to assist ministries of health and EPI programs to introduce birth dose vaccination. I welcome you all, and I'm looking forward to a good presentation and lessons that will be learned from the various experiences from the presenters. The first presenter for today will come from Nigeria, Dr. Basi. Dr. Basi, if you can unmute your slide. Yeah. No, sorry, let me go back. Yeah, the first presenter is actually Julian Kabore. Julian Kabore comes from WHO Afro, and he's a hepatitis B immunization officer in the WHO regional office, and he has been having a lot of work related to hepatitis B in the African setting. So Julian, if you can put your screen, if you can share your screen, and you can take it over from here. Thank you so much and welcome you all.
All right, thank you so much, Henry, and good afternoon, good morning, everybody. And sorry, oh, okay, so I will be sharing my screen. I don't know if you see it now.
Yes, they are there.
Okay.
Mm.
Okay, I put it in presentation mode. And
There we go.
okay. So can you still see my screen because it says it has stopped? I don't know. All right, and good afternoon again, everybody, and thank you for and welcome and thank you for coming to this meeting, and thank you, John, and all the team for organizing, helping to organize that. That's a very important thing for us in this region. And again, as Henry said, I am the focal point for hepatitis B immunization in the WHO Regional Office for Africa. And I'm going to just talk today about accelerating the introduction and scale up of the birth dose vaccine. So, sorry, my slides are not moving.
Julian, would you like me to share for you?
Okay. Well, yeah, I think that would be better.
There you go.
Okay, thank you, Lindsay. And I just want to start here by just reminding that hepatitis B is target for elimination, and is part of is one of the target of the Sustainable Development Goal at the global level, and is part of the third goal, which is called for good health and well-being, and is along have AIDS, tuberculosis, malaria, neglected tropical disease, waterborne disease, and other communicable diseases. And for hepatitis, the indicator for that target to control hepatitis is the prevalence of the antigen, the surface antigen among children, which really indicate the chronic infection. And in 2012, the World Assembly that regroups like 194 countries, they adopted the Global Vaccine Action Plan that gives a vision for immunization for the decade. And the performance indicators that were set in this immunization vision for the control of hepatitis B was to attain 90% national coverage and 80% district coverage of both hepatitis B birth dose vaccine and the third dose of the hepatitis B vaccine by 2020. And in 2016, the World Health Assembly again endorsed this time a global health sector strategy, which called for elimination of hepatitis B, of viral hepatitis in general by 2030, with a target of less than 0.1% prevalence of chronic infection among children less than 5 years of age by 2030, and a milestone of less than 1% by 2020. And for the immunization performance, was recommending calling for 90% coverage of both the third dose of the vaccine, as well as the birth dose at 90% by 2030, and 50% coverage by 2020 for the birth dose. Next slide, please. Now, what happened at the regional level? From those global decisions at the regional level, the regional committee, which is regrouping the 47 countries in the region, regrouping every year. And in 2014, they adopt 2 resolutions regarding the control of hepatitis B. And one of the resolutions was to endorse the regional strategic plan for immunization for 2014-2020. And in this plan for the control of hepatitis B, it was to targeting to control, to decrease the prevalence of the surface antigen among children less than 5 years of age by 2% by the end of 2020, and have at least, and that from a baseline of 3.2 at that time in 2014. And also to have at least 25 countries that have introduced the birth dose in the routine schedule, and that from a baseline of 7 countries at that time. And the other resolution was to really to scaling up all activities for prevention of viral hepatitis infection, and that included increasing the coverage of routine hepatitis B vaccination, introducing the birth dose, and vaccinating health workers at risk and at-risk population. Next slide, please. Right, so I'm not going to spend much time on this thing because as Henry mentioned that at the beginning, the target for the next slide, right, thank you. So I think Henry already mentioned that. Sorry, can you go back, just the last slide, please? The previous slide, please. I just want to mention that, well, but no, not this one, the previous slide. You go back. Go back again. All right. So as I was saying, so Henry already mentioned that it was here was just to contrast how the prevalence of hepatitis B surface antigen is still high in the Afro region compared to the other countries in the world. You can see here the prevalence on your left side in the table, and on the right side, the map showing the coverage of hepatitis B birth dose. And you can try to make the correlation and see that it's in Afro. We still have a lot of work to do. Next slide, please. So now, what do we do? What now when we want to accelerate and introduce the birth dose, what can happen? So the first thing what we need to do is really to advocate for national commitment, because that's the only way we can really get to the introduction phase. And for this, we need to really have evidence, to gather evidence around to show the burden of the infection in the region, and also to estimate the true risk of transmission from mother to child. And by doing that, we'll be like to sero survey among children or pregnant women. And I think we discussed that in the past meeting. And that will really help to inform not only the decision maker, but also to inform specifically the NITAG, the National Immunization Technical Advisory Groups, that will really look into education and that will recommend the introduction of the vaccine and also to provide guidelines for the vaccine itself. So the second point, as I say, was really to engage all stakeholders, to put them at the table before even getting for advocacy purpose and also for planning for the introduction of the vaccine itself. And here it's important to engage all potential decision makers, including for the Ministry of Health and the Ministry of Finance, because as we know, as of now, the vaccine is not yet is self-financed by the country. So it will be important that for those two ministries at least talk and discuss and plan together for the birth dose introduction and implementation. And also we need to make sure we involve the whole professional society and association like pediatrician association, gastroenterologists, because we know that they are really a big force in hepatitis control and to help to scale up the vaccination. And also to just mention the non-governmental organization, the community leaders, the religious leaders, and many other groups, including the civil society. All those groups are very important to really engage from the beginning, from the planning to the implementation of the introduction of the birth dose. Next slide, please. Now, when the birth dose is introduced, now what do we do? Some consideration to take into account is really to develop first clear policy and guidelines for the delivery. And we have to develop that at the national level as well as the local level. And those policies should make sure they clearly define what timely birth dose is, meaning that it should be really within the 24 hours of birth. Also in those policies, we want to make sure we clarify the time period the vaccine should be administered. We know that the vaccine is most effective 24 hours within the birth, but we also know that it provides some efficacy and some protection after the 24 hours. So we want to make sure the vaccine is still giving up to the first contact with the health services. And also it's important to define who administered the vaccine to the newborn and where is administered. We recommend really to administer in the maternity wards where it can be included in the routine practice to really make sure we're getting all the babies that are born. And also one thing to just highlight here is really to report the administration and timing, because that's also important, because as we know, we have to separate the reporting for the timely birth dose within 24 hours and the dose that are given later on. And also to mention here that we need to develop and adapt standards and guidance at specifically the local level, hospital levels, where we need to adapt the delivery manual, specifically in the maternity ward. And also, as we know that the maternity ward workers are not necessarily used to be doing immunization, we may need some job aids and posters that are there that we put in the maternity ward to help them do the job properly. And we also need to adapt the training materials, and we make sure we just train the EPI personnel as well as the maternity ward personnel on the policy and documentation that are there. We need to make sure we train both at the same time. Next slide, please. Now, when we want to scale up the vaccine, I'm just going to highlight here just some points that can be considered for really scaling up the vaccine. So, and we'll divide it in at health facility level and at home birth level, but we'll have really those considerations can really overlap. For the health facility, for instance, we have to make sure that we integrate the birth dose vaccination with the newborn care policies and practices. And we have said that that can be also really included in the guideline and the policy that are developed. And make sure that, as we said earlier, that we assign the responsibility for administering the birth dose. And another thing that needs to be really considered is really the stockage, to stock the vaccine near the delivery ward, or even better in the delivery ward, because I mean, when a child is born at night or during the weekend and the EPI people are not there, it can be difficult to be running and getting the vaccine at that time and maybe missing it. So it will be better to really have the vaccine in the maternity ward. And maybe we can put it in maybe a cold box or a vaccine carrier to keep it there if the maternity ward doesn't have those supplies. And another thing, we need really to reach out to the private sector to make sure all private sectors are provided with the birth dose so that they can provide it to all newborn in private facilities. For the home birth, we just want to make sure that the birth dose is administered as part of the home delivery, depending on the country, whether they go to reach out to the home birth at home with skilled birth attendant, or whether they bring it back to the health facilities for the postnatal care. We want to make sure we include the birth dose supply and kits in all delivery kits and train those skilled birth attendants to deliver the vaccine depending on the policy of the country. And another thing for the home birth, something that can help increase the coverage and scale up the vaccination is using single dose vials rather than the 10-dose vials to minimize wastage sometime where the healthcare worker may be hesitant to use the multiple vials, or maybe the compact pre-filled auto-disable injection. But these devices are kind of expensive, and I'm not sure if in that region it may be recommended, but in the countries that can have it, it would be good to use it. Can be good to use that for scaling up the vaccination. And also, as we know that the vaccine is heat stable, we can use it out of the cold chain. So that's a way we can explore to see how to increase, to help increase vaccination specifically for home delivery, but it can also even be used for the health facility level. Next slide, please. I'm just going to conclude here and stop here by just saying that, as we know, in the Afro region still has the highest prevalence of the highest prevalence of infection, chronic infection among children less than 5 years of age. And we know that to get to elimination, we really need the birth dose introduced in the country. So we need to accelerate the uptake of the vaccine. Not only do we need to accelerate the uptake, we also need to scale up the vaccination, because once it's introduced, we want to really make sure we can have at least 90% of the kids vaccinated so that we can reach elimination. So, and for really the introduction, we have to make sure we engage all decision makers and ensure the commitment for the introduction of the birth dose at the national level. And that's a very important thing. And once we introduce it, we have to develop and adapt the policies for national, local level, for the scale up, and also we have to adopt clear strategies for birth dose delivery in health facilities, in home facilities. And thank you very much for your attention. And back to you. Thank you.
Great. Thank you so much for that excellent presentation, Julian. And we are now moving to the next session where we'll be listening to countries that have already introduced birth dose. The first country that will hear their experiences and we are looking forward to learning from them is going to be Nigeria. And this presentation is going to be presented by Dr. Basi Okposon. Lindsay, if I can have the slide, please.
I will share from here. I'll share from here.
Okay, sounds good. Thank you so much, Dr. Okposon. Welcome, and please share your remarks.
Okay. Thank you, Henry. Good day, everyone. I'll be giving an update on behalf of the Nigerian team. And for us in Nigeria, we have 36 states and the Federal Capital Territory, 774 local government authorities with 9,565 political wards. And then we have our estimated population at about 225 million. The birth cohort about 9 million, and surviving infants 8.3 million. The proportion of deliveries by skilled birth attendants in Nigeria is 43.4%. Then with hospital delivery at 39.4%. Fertility rate for the country is about 5.39. And then 67% of our women gave birth in the 5 years preceding the survey period that we are putting this information. For us as a country also, we looking at the prevalence of hepatitis B and hepatitis C is at 88.3 contribution to the global situation. Then the prevalence of the hepatitis B with HBV infection is about 11 and 2.2 respectively from the data available at the ministry. And then the viral hepatitis B or C are undiagnosed in most of the instances. So this is increasing the likelihood of future transmission in the country. For the sex distribution, we have the male 62.6% and the female 37.4%. And then infection is seen mostly for age group 21 to 40 years. And then we're also monitoring our birth dose administration both on the admin platform and then the survey platform. Looking at where we are as a trend over a period of time, it started using the birth dose in 2004. And we are just looking at the trend, what has been happening in the country. And when you look at from the admin, where you have these light purple balls, you will discover that in 2013 to 2014, there was a very significant improvement, and that had to do with our change in policy where after 24 hours, we don't advise the health workers to give the women that bring their children the vaccination again. But then there was a revision to extend it to about 14 days after delivery. We could see a year after the marked improvements in the number of kids that were being reached. We're also having the unique and other surveys to monitor what is happening. Also using this trend graph, we're going to see from the admin, there have been a steady improvement from that 2013 over to 2015. 2015, 2016, we did not report admin because the country, after receiving the mixed NICS, was not giving emphasis to admin data. We were working more with the survey data. So we de-emphasized the admin coverage, then wanting to see what the survey data was looking at. And so we could see there was an improvement from the survey data, 29% in 2010 to what we could see in 2017 that gave us up to about 52%. And we are also doing the mixed NICS exercises ongoing now to see where we are for this year. Generally, there's been progressive. This also institutional delivery rate against the hepatitis B birth dose in the country between 2017 and 2020. Now on our screening and prevention policy, we have things on ground for the pregnancy period. Pregnant mothers are being screened when they come for ANC, for the HBs antigen, and then we also administer for those that are positive the nucleotide analog to the HBV positive infected pregnant mothers, and this is done at the third trimester, usually from 28 weeks upward. And there, the drugs are being given to them are the tenofovir and the lamivudine that are preferred and used depending on the clinician and the clinic the woman is visiting. Then suggested testing points for this is also both the public and the private clinics, and then also at blood transfusion centers. So these are the centers we ensure that this happens. At birth, the administration for the vaccination is prepared for 24 hours after birth. But like I mentioned earlier, we've extended this based on experience to 14 days to be able to reach out to more eligible children. And then for infancy, after the first birth dose, it is being given along with Penta at 6, 10, and 14 weeks. So looking at the national HBV treatment recommendations for those under 2 years as recommended by WHO, the drug of choice there is the Entacap. And then for adults 12 years and above is the nucleotide analogs, which is more of the tenofovir. And then it is the drug of choice, though the Entacap can also be used as an alternative where the first is not available. And then we also, for those that have renal impairment, the tenofovir is that is prepared for that age group in practice here. Activities leading to the introduction of the hepatitis B birth dose in the country were numerous before we started the introduction as a country. As at the time we started the introduction, there was no NGTAC, but the country consulted widely to know what to do. And so in 2004, we introduced it into the routine immunization schedule as a country. Then we're giving it at 6 weeks, where we now give the monovalent vaccines at birth, and then the subsequent doses are being given along with the hepatitis B containing pentavalent vaccines. So here we give the birth dose as a country, and then at 6, 10, and 14 weeks, the child is also being given along with pentavalent vaccines. So all immunization training manuals were also updated where our health workers were trained. The policy was updated in 2009. And then also the viral hepatitis control policy was also changed in 2015 to accommodate the changes in our vaccination schedule. We also updated all our recording data tools at all our health facilities so that the capturing of information and reporting was made easy. And then in 2014, there was an assessment after the review of the administration at birth, not beyond 24 hours after birth to the 24. We did an assessment to understand what effect the impact would be on the system. So we realized that the steady supply of the HBV vaccines was there in all our health facilities. And then 4 out of 5 health facilities visited during the assessment provided the HBV vaccine to our kids. And then the health workers were knowledgeable on when to administer the birth dose to our children. And even though the country immunization policy provides a referral point to the health facility for vaccination, all home deliveries practices is still very poor. The lack of knowledge from this cadre of persons to contribute to this. And so we are doing a lot of awareness creation on this. And then the cost of procurement of the hepatitis B vaccine is 100% by the government of Nigeria to be able to protect the kids. Then we're also on program activities that were conducted to improve the coverage, where the extension of the birth dose vaccination from within 24 hours to up to 14 days. This had been very useful. We could see the trend from 2014, what that contributed to the system. And then the health workers constantly being retrained. And then the maternal child health and expanded program immunization integrated into other services. And then the data collection for monitoring and evaluation is also being given attention as it relates to the hepatitis B birth dose. And there are also advocacies and community health educations ongoing on this to our TBS for them to understand and be able to refer their clients to the nearby health facilities for vaccination. And then scaling up of the strategies that have been outlined in the policy. Also addressing home deliveries, having regular talks and visits to them for them to refer to the hospitals near them for vaccination has also been ongoing. And then the cost for the activities, most time borne by the government and sometimes supported by our partners in country. The challenges we are facing have been on several ends. We'll look at from the service delivery end, what we have faced so far and what we've been working on to improve, which of course with the attention given to this have been useful. Those areas are challenges as it relates to service delivery had been the weak integration between the maternal child health and the EPI program, but this with the current program that is ongoing with the integration of services, this is improving. And then the vaccine coverage is still low in some areas, even taking place in the health facilities. And so we know the improvement, there's an improvement, but we are still not where we want to be. And then we are only making, for some of these health facilities in the country, they don't give the hepatitis B vaccine every day. They designate certain days of the week to give the vaccination. So infants not born on those days that the vaccination has taken place miss the opportunity of the mothers bringing them back to the health facilities. And then the vaccines are not pre-positioned in the labor wards. and the postnatal ward. So the mothers refer to immunization clinic after delivery, and some of them from discharge, they never come back to go to these facilities. Compared to if we had an instance where these vaccines are pre-positioned at the labor ward and postnatal ward, it would be very helpful. So we are advocating and pushing for this to happen, and most of the facilities are keying into this. Then it's about 62% of the bed in Nigeria are taking place at home. So if this is happening, the TBAs, most of them that are attended to these beds at home are not referring the women to the facility for vaccination. We are placing incentives for most of these home delivery so that for those in some state have taken action on this, they acknowledge and award those that take care of bed at home who refer people to the clinic. And this has also been helpful and leading to an improvement in the vaccination in the country. And then our health workers do not give hepatitis B to low bed weight and premature newborns. Most of them, if they see the baby not that looking that fragile, they will not want to give this to those children. But we are encouraging them to do the needful so that these children will be protected. And then some health facilities do not retain mothers in the labor ward for this period and support them to give the vaccination to the children. Then a number of secondary facilities do not conduct routine immunization. They think they should offer secondary and tertiary services and not immunization. But with this, in our policy, we are reviewing the policy, the secondary tertiary institutions are expected to offer routine immunization, and this is changing. We're also seeing gap in the capacity building in some of the health workers in some facility, especially as it has to do with the private sector. And this also has to do mostly with their interest, where most of them are not really giving attention to the vaccination of the birth dose for hepatitis B. So this is also being inbuilt and included in the trainings for them to improve on this aspect of them. And then for stock availability, the inadequate coaching equipment at site of delivery for some of the areas make them not carry all antigens to the site. But this, with the supplies we are having from the government and partners supporting the cold chain system of the country, it is changing also. And then the social cultural factors also contribute to some of the poor coverage in some areas we are seeing. For instance, the high proportion of home deliveries compared to facility delivery, delivery by the unskilled bed attendant, and then cultural restrictions of women in some areas to remain indoors within the first 40 days of delivery. So these kind of customs and beliefs affect the mothers bringing out their children for this first dose vaccination. And we did study at Enugu to try to understand what the reasons could be for the poor coverage in some areas. And some of the things that came out from the finding there was vaccines not being available at place of delivery. Delivery did not take place on immunization day where the parents visited, and then maternal lack of awareness of the hepatitis B birth dose timing, and then vaccine stock out in a few instances. And so the team has been working to ensure that we address these gaps. And then for improving the hepatitis B birth dose vaccination, a lot is being done on this as a country, from the policy review to integrating the birth dose vaccination as part of the tertiary newborn care package, assigning responsibility for administering the birth dose to most of the people in our labor wards and the pediatric wards, and then keeping a stock of vaccines in the delivery ward. And now we're reporting through the SMS in most facilities for now, including the private sector in the birth dose vaccination, and then engaging the communities for awareness creation. We have several opportunities as a country to improve on the coverage as it relates to the hepatitis B birth dose, from the high presence of international partners and donors who are supporting, to using the opportunity to new vaccine introduction to revise and produce data capture tools, and use the opportunity to also educate our manuals, we have our policy, we have our checklist, and everything that we share with our health workers that keep them busy for them to be able to understand what we want them to do. So these are some of the reference materials that we are using to be able to put these few words to share with this great team, and for also to seek for guidance on what we need to do further to be able to move forward, and also encouraging countries that are yet to introduce the birth dose to also be part of it. In conclusions, an effort are ongoing to sustain and improve the hepatitis B birth dose vaccination in the country. And we want to use the opportunity to thank all our partners who give us support to be able to be where we are as a country. Thank you all our great partners and donors on this. On behalf of the team here, we want to say thank you for the opportunity you're giving to us to be able to share the little work that is ongoing in the country. Thank you. Over.
Thank you so much, Dr. Bassey, for that very good presentation. I think we have a lot to learn from Nigeria, and Nigeria having a very huge population and also having had introduced birth dose for quite some time now. Of course, they have had their fair share of challenges, but they have also come up with ways to try and improve that. Just to ask one question, I think from the charts, there is a question about birth dose coverage. What is it at the current moment? And two, you have extended the duration where the birth dose is recommended from within 24 hours and allowed a window of 2 weeks. I don't know how that will impact on the timeliness of birth dose, which is really more effective if it's given within 24 hours. Maybe you can quickly respond to that as we prepare for the next presentation, and we'll have follow-up questions after the next presentation.
Okay, thank you, Henry. For the birth dose extension, we realized that when it was within 24 hours, once the mother comes the following day, a day after delivery, the health workers will say we can't give to the child. We were permanently below 20% in coverage. We were not reaching. And so we had to reach out and sought for advice and guidance on what we could do. I remember then we were in touch with the national office of WHO, the regional office, the global team. And then we were guided there was a need to extend to 14 days, not beyond it. The message remained that the proper time for vaccination is 24 hours. But to the health workers, for any reason, if a mother is seen coming to the health facility after 24 hours, but less than 14 days, they should not send them away. So the message is still very consistent that within 24 hours is the best. But if for any reason, especially looking at 54% delivery at home, looking at the cultural background where some women, if they deliver, they will not be allowed to go out with their baby for 40 days. You realize that if nothing is done, we will be missing these children. And so with the guidance that can still be given, 24 hours is preferred and is the constant message. If the mother is seen within the 14 days, they shouldn't send the child away. They should give that dose. And then the child will now come at 6 weeks to take the penta, the 10 weeks, and then the 14 weeks. So, and we saw when we did that in 2013, the coverage moved from about 29% to about 74% of the vaccination in admin. And for that same year, the survey that came out gave us about 52% in survey, which the best before then was 19%. And so we have always sustained that, and we hope that we are doing more to see how we improve the health workers' knowledge and the mothers themselves to come out faster. And then for the coverage, okay, I think I've combined the coverage and the administration trying to mention it. Or we've seen that there have been some steady improvements in the coverage compared to what we used to do in the past. But this, we are not yet, we have just, the mixed NICS is ongoing. So once the mixed NICS for 2021 is out, we'll be able to compare to the last mixed NICS 2017 that we had. But from the SMART survey, we got up to about 69% in 2020 from the SMART survey. And this is far better improvement compared to what it used to be before 2014. Thank you, and over.
Thank you very much. Very good. Really appreciate that information. And I think we have to recognize that we fully agree that if an infant's there, go ahead and vaccinate. But at that stage of life, of certainly after 7 days of life, the impact of interrupting perinatal transmission is greatly reduced. And the main benefit at that point is to prevent early horizontal transmission, within the household or community. And I think Nigeria and all of the countries around the world, frankly, including the United States, have to continue to find ways of delivering that vaccine as quickly as possible after birth. Now, even though our coverage numbers may look lower, at least they will be more accurate and revealing the level of protection to interrupt mother-to-child transmission. So, we look forward to working together to see how we can improve timely birth dose coverage in Nigeria. Thank you.
Yeah, thank you so much, John, for those remarks. So next, I'll ask Lindsay to share this next slide so that we can move on. So the next presentation is going to be from Botswana. We have Dr. Sidimo Gavankore from the Ministry of Wellness. She has been a registered public health medical physician working in the Ministry of Health and has been working a lot on hepatitis and other areas. Welcome, Dr. Gavankore. We'll have the presentation presented. It is a recorded presentation, but we'll have her available later after the presentation to answer any questions that may arise.
Good morning, good afternoon. My name is Dr. Sadimo Hasanelwe Gavankore in the Ministry of Health and Wellness. I'm working with the Primary Healthcare Support Division, and I have compiled this presentation. The first few slides will be shared for you by our Early Childhood Development Focal Point, Memma Zanele Busa, who is retiring end of the month. So she'll be sharing with you the introductory slides, and I will conclude with the rest of the presentation. So over to you, Memma Busa.
Good morning, good afternoon. My name is Zanele Busa, as she has already mentioned. I'm going to be presenting on the background of hepatitis B in Botswana. First of all, I'll give you the statistics. We have 52,306 live births per year. And in hospital beds, we have 98%, which is 52,206 live births. And this is according to the National Statistics Office. Hepatitis B prevalence in an adult HIV center population was done in Gaborone, and it is 53%, according to Patel et al. Hepatitis B prevalence from research. There is no routine data for prevalence survey done at National Health Lab. And an estimated prevalence of hepatitis B is in the general population, it's only a HIV positive population of 10.6. And this was done by Wester et al. In 2006. Estimated prevalence of hepatitis B among pregnant women is 2.1% in 2018, and this was done by Mbangiwa et al. And samples show 1.1% HIV negative and 3.1% HIV positive. Estimated prevalence of hepatitis B antigen among children below 5 years. Below 18 months, it's 0.67%. According to the draft publication of Botswana Harvard Partnership. And for BCG, BCG is also given at birth, and also we provide vitamin K at birth. In 2019, our coverage was 78% for hepatitis B3, and hepatitis B at birth was 73.8%, almost 74%. Hepatitis B screening and prevention policy. There is no policy on hepatitis B prevention of mother to child. There is no hepatitis B antigen screening during pregnancy. We only do it for syphilis, gonorrhea, HIV at first visit, second and third visit of antenatal care. Treatment guidelines for hepatitis B infected pregnant women have not been included in the current safe motherhood guidelines. The introduction and coverage improvements. The EPI program was established in 1979. And before then, the vaccination was done sporadically. And to those who knew about it or who thought they needed to be vaccinated or their kids to be vaccinated. A baseline survey was done in 1989 by the EPI program and some international partners. And the prevalence was at 12%. And therefore, it was suggestive that we should start the hepatitis B program. This includes hepatitis B as one of the vaccinations for under 5s. No evidence of NITAG involvement, but there was a recommendation, which I've already said, that they decided the EPI program, Botswana EPI program decided to start the program. And this was done in 1992, and in 1993, the piloting started. Program costs were covered by the government at 100%, and private sector gets free vaccines from government and charge for administration. Almost all the deliveries occur in the health facilities. Dr. Sadimo will continue with the presentation.
Thank you, Zanele Memabusang, for that excellent coverage of the background. I just wanted to highlight some of the challenges that we are experiencing with the hepatitis birth dose program and the immunizations in general. There's a problem with documentation for vaccination. And this is where you can see some of the discrepancies in the coverages, which is something that we're working on, strengthening our M&E systems and our surveillance systems, which is part of the restructuring processes to try and strengthen our health systems in country. We noticed when we did a birth dose assessment in 2016 that the premature and sick babies were offered the HepB birth dose vaccine on discharge, and they're not given the vaccine and in the first day of life, in the first 24 hours. And we try to increase awareness that the birth dose should be given in the first 24 hours. The opportunities for hepatitis B birth dose coverage improvement are many. We need to really strengthen collection of data on hepatitis B prevalence. Maybe start with our National Health Lab doing surveillance, and start with a policy maybe to institutionalize the surveillance for hepatitis B, especially at ANC and for triple elimination. We need to evaluate the general immunization program to see really what is causing this lag in coverage for immunization. What are the health systems challenges for HepB birth dose and other immunization and other antigens that have low coverages? We know that there are a lot of health systems challenges. A lot of our mobiles are not being accessed, which usually outreach used to cover these mobiles when there was transport from local authorities. And because of these transport challenges, many of our mobile stops are not reaching out to cover the high coverages that Botswana used to experience many years ago. We would like to improve coordination and implementation of birth interventions at program and planning level, at the program level and at national level. Because if once we integrate and coordinate at planning level, it's easier for the programs and the districts to also integrate. And most importantly, we really need to resuscitate perinatal committees. In the earlier years, Botswana had very strong perinatal committees where the obstetricians and the pediatricians used to audit neonatal deaths, maternal deaths, perinatal deaths in the facilities. And we had strong district structures that used to investigate these cases and improve quality of care. So we would really like that revitalization of those primary health care structures that used to exist in former years. We would like to also include hepatitis screening for couples at ANC. We have a couple screening program, which is with the HIV program. But we would like to see this fully integrated into ANC, where we strengthen the surveillance for all the STIs, namely hepatitis, HIV, and syphilis. And we strengthen couple testing at the start, and even develop a prenatal service in the country if that is possible. We would like to train midwives on integrated EPI, MCH, and it also includes PMT-CT, because they are currently working in silos. They have different budget lines, and even though there's a RAMCA strategy, this strategy has not really been fully implemented, and integration has not been fully realized. We would like to publish data from studies conducted, maybe follow up on the work that was done with the University of Antwerp in 2008, and carry on with some support from partners to make sure that we do more studies. Currently, we're working closely with the Botswana-Harvard partnership, but we would encourage to have more partners to work with the country. We would like to secure funding for the immunization program, including the hepatitis antigens, and we would like to strengthen the immunization, the EPI program in country, especially to see where the hiccups are in the health system and how we can really get our coverages back to the 90% that we used to enjoy. We are looking actively for funding to print new MCI guidelines and also get technical assistance to make sure that these guidelines are are updated and are current. We need support from partners to make sure that they're relevant to the elimination targets that have been set globally. And lastly, we need additional resources, human resources, and as well as financial for triple elimination to be realized. And one of the main pains that we experienced is that our domiciliary support visits that were used to be done by midwives are also not being done. And we would like to strengthen community midwifery and maybe have focal persons assigned to do such work. This slide will compile with the contribution of the maternal and newborn program, Jessica Mafasiswalo, and the MNE focal person there, Mr. Mudise, and the EPI manager, Maria Subaging, and my co-presenter, Mabusang, and the PMTCT HIV program manager, Majindwa. So thank you for your attention. Thank you.
Thank you for that presentation. We'll move because this is really related to Botswana. The next presentation is going to be from Dr. Motswedi Anderson, who works very closely with the Ministry of Health. She had done some work on hepatitis B, and this is her time to present. Play the video because it's also recorded. And then after this session, we're going to have questions related to Botswana.
Good afternoon. I'm Motswedi Anderson. I'm going to share on studies which evaluated hepatitis B virus vaccine efficacy in Botswana. The first study was on HIV positive and HIV negative pregnant women and their 18-month-old infants. Of this, using samples collected between 2010 and 2012. Of the 752 screened pregnant women, 2.1% were hepatitis B surface antigen positive, while 6.6% were occult HBV positive. 9.8% of the 143 infants were HBV DNA positive, and all of these infants were HIV negative. We couldn't classify the infants' infections as either occult or chronic because we didn't screen for hepatitis B surface antigen due to insufficient sample volumes. Here are the characteristics of the hepatitis B surface antigen pregnant women. This shows that 3 HIV negative pregnant women had high HBV viral loads, both at enrollment and at delivery, and they were hepatitis B E antigen positive, both of which are considered as indicators of increased risk of mother-to-child transmissions. In fact, one infant from these mothers was HBV DNA positive. The second study was on HIV exposed but uninfected 18-month-old infants using samples collected between 2011 and 2013. And as a build from this time around, we started with hepatitis B surface antigen screening for obvious reasons. None of the 304 infants were hepatitis B surface antigen positive, and 65% of the infants had received a timely birth dose, which is in line with the multi-center study which reported the Botswana timely birth dose to be at 74%. How did these infants respond to the vaccine? Only 63% of the infants achieved complete HBV protection with titers of at least 100. 3 of the infants didn't achieve protection with titers which were less than 10. Unfortunately, again, due to insufficient sample volume, we couldn't test for HBV DNA or occult HBV. In order to solve the problem of insufficient sample volume, we decided to use dried blood spots. This time around in both HIV positive and HIV negative infants, using samples collected between 2016 and 2018 from the Botswana National HIV Program. And HIV positive infants had a significantly lower response to the HBV vaccine. This is after receiving all the 4 doses. Consequently, a lower proportion of the HIV positive infants had protective HBV titers. It should be noted that this difference is not due to the difference in age, as the HIV positive infants actually were significantly older than their HIV negative counterparts. 3 of the 449 infants were hepatitis B surface antigen positive, 2 of which had protective titers which were greater than 10, and there were no vaccine escape mutations in the amplified region. What are the take-home messages? We reported high HBV viral loads and HBe antigen positivity in HIV negative pregnant women. This calls for further strategies such as the use of antiretroviral therapy in this group. Only 65% of the infants had complete HBV protection at 18 months, and HIV positive infants had lower response to the HBV vaccine. We also reported the presence of HBV breakthrough infections in both HIV positive and HIV negative infants. This calls for further studies in the infants which are 5-year-olds, which is regarded as the proxy for HBV incidence studies. We also call for studies which will maybe check if an additional dose can be beneficial to those with suboptimal response to the HBV vaccine. We lament the lack of national representative data. Nevertheless, these studies provided important baseline data. I would like to acknowledge Dr. Simane Hasitsi for supervising these studies, the HBV group shown here, BHP management, and the funders. Thank you.
Thanks a lot. I think we have learned some few things from Botswana, which is very encouraging because Botswana is one of the countries that has a very long history of having birth dose. If presenters from Botswana are online, I would want to pose one question, and anyone in Botswana who works in the Ministry of Health can possibly respond to this. In the presentation, it was reported that there is this strategy of training midwives and integrate EPI with MCH activities, which I think is a very good strategy. But I wanted to understand, will the midwives be able to take up some of the roles that the EPIs do in terms of vaccinating the newborns, as well as recording the vaccine doses that are given after that vaccine is offered? Anyone from Botswana, please feel free to unmute yourself and contribute to this. And also other countries that potentially have the birth dose in place. I think it would be nice to learn from you. Is Dr. Sidimo there?
Yes, I'm here. I don't know if my colleagues from Botswana, from the MCH or EPI program are online, but our midwives are the ones who have been giving the HBV vaccination in the first 24 hours. They also give the HIV mother-to-child nevirapine in the first 72 hours. They also give the BCG and the vitamin K at birth in the first. So it's the midwives, they have been doing it. But what is not integrated is that the program, for example, PMTCT for HIV will train them independently to do what they want. The nutrition department will train them to, put the child at the breast in the first hour for early infant breastfeeding. And so each program trains them separately. And so it's up to them to see how they coordinate all these activities. So what we would like to do is, because all the interventions are very critical in the first hour, first day, first week, work at national level now to see how we can have an integrated training to make sure that these critical interventions are done in a coordinated manner. and everything, the midwives are not leaving anything behind, be it kangaroo mother care or cord care, and so on. So the birth dose has been the mandate of the EPI program, but there's no integrated training for the midwives. They're the ones who arrange the activities according to their schedules and their workloads.
Okay.
Thank you.
Thank you very much, Dr. Sidimo. I want to call upon Nigeria, Dr. Basi, again, following on that question related to midwives and the role of giving birth dose instead of relying on the EPI staff. Have you contemplated on that? And maybe you can respond and share some light on that. Dr. Basi? Okay, I think we probably don't have him on, but so John, do you want to continue the discussion?
Well, it's a very well developed program in Botswana, and be interesting to understand why coverage has dropped. So I agree for the need for an evaluation to look at those types of questions. I take from the last response that your birth dose coverage percentage that you reported of about 74% does represent timely birth dose. Nigeria mentioned that they were defining a birth dose up to 14 days, which is, very problematic in representing mother-to-child transmission prevention. But just to, reinforce your description of your program, please, when you mentioned 74% coverage, you're referring to vaccination within 24 hours after birth or very, very shortly thereafter. Is that correct?
Dr. Sidimo?
Yeah, yes, I think that is correct, because after the assessment that was done with CDC and WHO, we tried to stress the importance of giving the vaccination in the first 24 hours. But it's usually, the delay usually happens like in Nigeria with the premature babies or the sick babies, where the pediatricians and the midwives tend to hesitate to give the birth dose. So I think we would say that 74% would be in the first 24 hours for most of the cases, more than 90% of the cases.
Thank you very much. Also, I appreciate the data from the study data looking at the immune response to vaccination for HIV positive and HIV negative children. And I can see there is a small decline in the response, but when you look at that graph, the great majority are still achieving that 10 international unit level that's considered to be protective. So there's certainly not a reason to choose to defer vaccination from an HIV positive infant or infant born to an HIV infected mother. But I think, again, it stresses the importance of completing the vaccine series, which was not done in a sizable percentage of that population presented, and to have, whenever possible, to test the infants to identify those who failed vaccination so that you can identify them. And I think lastly, the data shows the availability, the importance when you have good vaccination coverage of then adding on maternal screening so that you can direct additional strategies such as antiviral prophylaxis. Thank you.
Thank you very much, John. I think this is a lot to learn, and the next series of countries that you're going to learn from are countries that are in the process of introducing birth dose, and they will share their experiences in the whole process. And as they share these experiences, I want all the participants to start thinking about what technical assistance needs do countries require to help in either improving the coverage for birth dose or even in the introduction of birth dose, and we can have discussions around that later on. So the next country, Lindsay, if you could share the slides, is going to be Ghana, and we have Dr. Atsu Saeke Kwayu, who is a public health specialist in the Ghana Health Service and has been responsible for the management of the National Viral Hepatitis Control Program. Dr. Atsu has had a lot of experience as a health team leader in Ghana, and is going to present a recorded presentation, and thereafter we'll have some few questions, an opportunity to ask him questions. So as he presents, I remind you to either drop a question in the chat box and also be ready to ask him after his presentation any questions that might arise. Next, just play the clip for Dr. Atsu.
Hi, good afternoon, everybody. My name is Dr. Atsu Sakekwao from Ministry of Health, Ghana Health Service, Ghana. I'm presenting on Hepatitis B Birth Dose Introduction Plan in Ghana. Ghana, as you know, is a small country in West Africa, population of about 31 million last year, with expected births of 892,000. Women's health, at least there is one ANC visit by 97% of pregnant women, and 73% deliver in health facilities. We take a look at the trend of BCG and OPVO and Penta-3 vaccination coverages. The coverage for BCG is quite high over the last 5 years, and that of OPVO is within 70%, reflecting the difficulty of early administration of this vaccine to newborns. As a country, we have a quite high coverage of Penta-3 within 90%. In fact, the last coverage last year was 96.9%. Looking at the evidence of hepatitis B using surface antigen prevalence, we had some studies, published data that looked at the prevalence in general population and estimated it at 12.3%. This was published by Ofori, Asenso, and Ajiman in 2016. Prevalence among pregnant women is really unknown. Luckily for us, there is an ongoing CDC-funded seroprevalence study to estimate prevalence of surface antigen hepatitis B among pregnant women. Children under 5, the prevalence is modeled, estimated to be 0.64%, I think largely due to the administration of the pentavalent vaccine, which has reduced chronic hepatitis B among children. The process for the hepatitis B birth dose introduction. In the country multi-year plan of 2015 to 2019, hepatitis B birth dose was described as a potential new vaccine for introduction. But then NITAG, which is the National Immunization Technical Advisory Group, required evidence of disease burden. So in 2020, the CDC is assisting Ghana along with the WHO to develop a protocol to estimate the prevalence of hepatitis B among pregnant women using HIV Sentinel survey samples of 2019. So far, necessary approvals have been gained, and we are waiting for the study to commence so that the results will be presented to NITAG for their evaluation. The program itself will help to disseminate the results widely to build support and expectation for the birth dose introduction. We believe this request will be submitted to Gavi to support the government of Ghana in this regard. On hepatitis B screening policy, screening and prevention policy, on the screen, you could see that in our new maternal and child health record, there's provision made for birth dose of hepatitis B. So there is a high expectation that hepatitis B would be introduced somewhere in the course of time. The policy on prevention of mother-to-child transmission of hepatitis B is incorporated in principle within our antenatal care reproductive health policies. And the screening of hepatitis B among pregnant women is ongoing, even though it is not systematic nor reported. There are multiple rapid test kits in use, and many of them is difficult to tell whether they are of their efficacy. Normally, we have a Food and Drugs Authority that is interested in approving these kits before they are used, but many people use them without such approvals. The program also is yet to develop a testing policy or algorithm that can guide testing of hepatitis on mass scale. Now, we also are yet to update treatment guidelines for infected pregnant women in line with current WHO recommendations, which were released last year. So the situation in Ghana now is, even though in principle we accept the policy for preventing of mother-to-child transmission, it is not yet on public offer. Those who are affected by hepatitis B in pregnancy actually depend on imported hepatitis B immune globulin and birth dose hepatitis B, which are available privately to protect their newborn. Some of the challenges or the potential challenges that we expect, the most important one now is how to get early and convincing data for NITAC decision. We also foresee implementation challenges, including orienting our midwives to accept birth dose vaccinator role within labor wards. Because this also go with responsibilities, and you know not everybody likes additional responsibility. Documentation is an issue, how to get midwives in their respective locations to access the cold chain and have access to the vaccine to use within the 24-hour window is also an issue. And also the reporting requirements that come with administration of vaccines. We also look at the fact that some newborns are born outside health facilities. About 27% or so are likely to be born outside health facilities. And how to reach these people within 24 hours is a crucial issue. It requires early flow of information, availability of staff at the moment to vaccinate an affected child at home, and also availability of appropriate transport means to address, to reach the mother at the time that is required. We expect some of these to be challenges that will arise going forward. Some opportunities, let's say, encouraging situations on the ground that we believe can help us a lot is currently we are having research technical assistance from CDC and WHO for evidence generation. In fact, a second study on the risk of mother-to-child transmission of hepatitis B has just been submitted for ethical review. And we hope that once it is going through, it will be generating additional evidence in support of the first one on the prevalence of hepatitis B among pregnant women. Funding has been secured for both studies through CDC. As a country, there is a cold chain capacity in every district. Even though this might not be down to community level, we believe this can be accessible in times of need in most places. The midwives are also already used to situations of time-bound administration of vitamin A, maybe within 72 hours, antiretroviral prophylaxis to HIV-exposed newborns. And also we have a health system that is decentralized with nurses placed within communities, or what we call CHIP zones, community health planning and services zones. So we believe with these factors in place, it can help in the introduction of hepatitis B birth dose in the country. Thank you very much. Over to you, Henry. Thank you.
Great. I think that was a good presentation. I want you to hold on to your questions to that presentation and invite the next presentation from Ethiopia. And after that, we could pose questions and discussions after the Ethiopia session. So the Ethiopia session is going to be presented by Mulata Lemu. Mulata Lemu is a public health professional with over 20 years experience. He has served with the MOH Ethiopia National Immunization Program as a team lead and has a lot of work related to hepatitis B birth dose. He's currently a consultant with Affinet and working with MOH as well. So this is going to be a recorded presentation. So just sit and listen to it, and then thereafter we are going to have questions and discussions from this presentation. Thank you.
Good morning, good afternoon, and good evening, all. This is Murat. I'm a hepatitis birth dose consultant based in the Ministry of Health, Ethiopia. I'm seconded by AFNET in collaboration with the US CDC. I will present the Ethiopia's initial experience on hepatitis birth dose pilot implementation. Having said that, I want to highlight some of the basic information, the country basic information. Ethiopia has a population of close to 103 million. I think this country, Ethiopia, is the second populous country in Africa next to Nigeria. Of this population, around 3.5.
Apologies for that. Let me restart that.
Good morning, good afternoon, and good evening, all. This is Murat. I'm a hepatitis birth dose consultant based in the Ministry of Health, Ethiopia. I'm seconded by AFNET in collaboration with the US CDC. I will present the Ethiopia's initial experience on hepatitis birth dose pilot implementation. Having said that, I want to highlight some of the basic information, the country basic information. Ethiopia has a population of close to 103 million. I think this country, Ethiopia, is the second populous country in Africa next to Nigeria. Of this population, around 3.5 million is estimated of live births, which is 3.36% of the total population. The estimated surviving infant is 3.25 million, which is 3.16% of the total population. The proportion in skilled births in the country is estimated around 50%, which ranges from 26% in Somali region to 96% in Addis Ababa. With regard to the seroprevalence in different population groups, the estimated prevalence in the general population is around 7.4, and in among pregnant women it is estimated around 4.7, and in among the children under 5 years it is 4.4%. Which is this according to this information, we can conclude that Ethiopia is considered to have intermediate to high prevalence of hepatitis B virus infection. To see the hepatitis birth dose vaccination coverage in Ethiopia, no hepatitis birth dose vaccination service so far in Ethiopia actually, except the pilot implementation that we are starting to go through. The infant hepatitis B vaccine was added to EPI series in 2007, The current 3 doses of pentavalent B vaccine, as the schedule is at the age of 6, 10, and 14 weeks. This is an ideal schedule for Ethiopia. The estimated coverage level, according to Ethiopian Demographic Health Survey 2019, is the Penta 1 is around 76%. The Penta 3, the third dose, is around 61%. With including this, the BCG coverage rate is estimated around 76%. So this is, we can understand that this coverage level is really suboptimal to ensure the population have the immunity. This slide shows the distribution of hepatitis B infection and pentavalent 3 coverage. So I think we have around 11 sub-regions here. So when we look across the regions and across the setup, rural urban, so most of the regions here showed that they are under the high burden, and then some of the regions are like in the intermediate burden. So we can understand that at national and subnational level, the burden of hepatitis infection is really very high, most of the sub-regions. And then generally we can conclude that it is the countries in high level, high burden of hepatitis B infection. So according to this study finding, the national prevalence was estimated around 9.4%. So this is actually, we cannot definitely link, but the pentavalent vaccination coverage by region shows this. Unfortunately, if we look, unfortunately or fortunately, the Afar vaccination coverage is around 26%. When we look at the hepatitis B infection rate, it is really, it looks a linkage, I think, even though it is, because this is a factor, one of the risk factors for the hepatitis B infection. So even though most of the regions, the coverage of the pentavalent vaccination service, which includes the hepatitis B vaccination, infant hepatitis B vaccination, in most of the regions is less than 80%. So that is the key message from this graph. It has many messages, but you can see and interpret from your perspective. With regard to the existing guidelines and strategies in the country, Ethiopia has a national strategic plan and guideline on prevention and control of hepatitis, viral hepatitis. It was developed in 2016 and served up to 2020. These documents are under revision currently for the hepatitis prevention and control. We have a guideline, and Ethiopia has a guideline on the screening and treatment of pregnant women. The pregnant women are under high risk groups based on the status if they are positive. So the guideline, there is a guideline for treatment of the pregnant women is available, even though the actual practice has many drawbacks and which need further assessment to say exploratory. We can conclude that the country has guidelines, the necessary guidelines and strategies in place, and it needs to work on the actual practice in the ground. As I have said earlier, Ethiopia has started the pilot implementation a few months back. I want to tell you what activities we had done prior to the start of the hepatitis B piloting. In our comprehensive multi-year plan of EPI from 2016 to 2020, we had indicated that hepatitis will be introduced in 2018, but unfortunately it was not realized at that year. Since August 2017, the Ethiopian National Immunization Technical Advisory Group had initiated discussion on the national hepatitis birth dose introduction. following the request from the Ministry of Health. We have a research advisor group which serves to generate evidence for the maternal and child health services in the country. This council had generated an evidence on economic evaluation on the introduction of hepatitis B to introduce in the immunization program in Ethiopia. The finding was really very supportive for the introduction. The incremental cost effectiveness ratio showed a USD of 110 per days averted. So for the further read, I think the link is indicated there. The Ministry of Health and the stakeholders following these evidences, based on the above evidences that I have talked about, had developed a policy brief and concept note on the piloting. Initially, we were discussing to start it on the urban setups, but later we just agreed to include all the combination of the setups from the country. After then, the detailed proposal developed and shared with key stakeholders, and then budget mobilization was done. Pilot site was selected, and all the sites were informed properly. The necessary preparations, including the capacity building and social mobilization activities, are done. And then now the pilot implementation is really underway, as I have said earlier. So this is the objectives that were indicated in the concept note to identify and address programmatic and logistical challenges and barriers during the vaccination, to test the strategy, and then draw lessons learned and document best practices to inform for the scale up of the hepatitis birth dose introduction. Thirdly, it was said to determine the hepatitis vaccination acceptance by different target groups like the healthcare workers, caretakers, and other relevant beneficiaries and influencers. Fourthly, it's set here to estimate the hepatitis birth dose vaccination coverage, both timely and late vaccination coverage. In Ethiopia, we said that timely hepatitis birth dose coverage, if it is provided within 24 hours, and then if it is provided after 24 hours, up to 14 days, it is labeled as late coverage. So fifth, it was set to determine the impact and effectiveness of hepatitis birth dose in averting hepatitis infection rate. Last but not least, it is included to determine the cost and cost effectiveness of the pilot introduction, just to get substantial insight for the full scale nationwide universal hepatitis birth dose introduction. These are the objectives of the pilot introduction in Ethiopia. With regard to the designs indicated in the pilot introduction, it is to redesign a new vaccine delivery point, because usually the vaccination service in Ethiopia is provided in vaccination rooms. In case of this birth dose, we need to establish the service delivery point in delivery and PNC units. And then there is a task shifting and sharing will be in place, and it is in place now. Vaccine logistics, training, and linkage between the integration as well as the coordination among maternal, child health, and vaccination services need to be ensured. With regard to the setting, as I have said earlier, we have three settings in Ethiopia: urban, agrarian, and pastoral. So the pilot is already implemented, has been implementing in all these three settings. In terms of the health facility levels, all types of health facility level, hospital, health center, and health post. This health post is operating by health extension workers in Ethiopia, and even including the outreach and the mobile sites are included in the pilot implementation. The others like pregnancy and birth notification, institutional delivery, increasing institutional delivery, reaching home births to attain and sustain high hepatitis B birth dose vaccination is included as methods and designs of the pilot implementation, which is already underway to translate into reality. What I want to show from this slide is just 4 regions are included in the pilot implementation, one from urban and one from pastoral, and the 2 are from agrarian. We had using scores based on these 4 indicators. The indicators that were included for the selection criteria was antenatal care coverage level, the skilled birth attendant coverage level, postnatal care, especially the PNC within 2 days coverage level, as well as seroprevalence of the infection was included. The weights we had given is indicated here. The first three indicators were containing 20% each, and then the seroprevalence status was given 40%. Based on this, Addis Ababa, Tigray, Afar, and Amhara were selected out of the 11 regions that we have in country. So Addis Ababa is from the urban setup, Tigray and Amhara is from the agrarian setup, and Afar is from the pastoral setup. You can see the detailed rates every region has got from that competitive selection criteria. With regard to the relevant information on the pilot introduction, we have developed the recording and reporting tools, as well as training materials on hepatitis birth dose pilot implementation. So all these recording and reporting tools, as well as training materials, are prepared and shared with all the pilot sites, including vaccination. They will be available in vaccination, delivery, and NICU delivery points. Sorry. With regard to the IEC materials, information, education, and communication, fact sheet, brochure, and poster were prepared, as well as provided to all sites. This is the initial performance from two districts, as it is displayed in the table. You can understand that Amhara Goncha district had started on the month of January, and Addis Ababa was started on February 2021. So the coverage level, the facility delivery, the home delivery, and you can see the vaccinated within 24 hours, and as well as for hours up to 14 days. All of capturing the newborns and providing the vaccination services. For example, in Amhara, was already the newborns who have born at home. Some of the newborns are getting on lately time. So all the health facility, all the newborns who have born at the health facility are getting almost the on timely immunization services. Whereas in Addis Ababa, even though there is no home delivery reported, on the month of February it was around 50-60%, but on the month of March, almost all of the newborns who have almost nearly all of the newborns had getting the birth dose vaccination services. With regard to the challenge during the introduction, even the place of birth is really one of the challenge, as we have seen from the initial performance data. Though facility delivery or high home delivery is one of the challenge, especially for the agrarian setups. Socio-cultural factors. Home deliveries in Ethiopia, there is a practice of stay at home for 45 days after delivery. If mothers have given birth at home, there is a rare practice to visit health facilities. This is really one of the challenges to address hepatitis birth dose introduction. Thirdly, there is additional cost. This is very obvious that cold chain equipment, equipping cold chains and training, providing training for the delivery and postnatal or neonatal intensive care unit staff is requiring a cost. The time factor is one of the challenge, as we have providing the service within 24 hours is an ideal recommendation to adhere. The WHO recommendation, but unfortunately, it is very tough to get the newborns, especially who are born at home. So this is one of the challenges. The strategy is new, as I have said earlier, establishing and strengthening new vaccination service delivery point and providing the service within 24 hours of birth to all newborns, regardless of the place of birth, is not an easy task. These are the challenge, some of the challenges that we have in place. With regard to the opportunities of the introduction, the pilot implementation, as well as even the birth dose introduction, it is very obvious that hepatitis elimination is getting a focus at national, even at global level. This effort is already included in the SCDG. Funding and HA support is available for this pilot implementation. Planning to generate local data from this pilot implementation to inform the full scale introduction is another opportunity, another golden opportunity that we have cited here. There is even a promising possibility of getting additional funding and TA support from stakeholders and partners for the full-scale universal hepatitis birth dose introduction. On the next steps, I think effective use of technical working groups will matter to generate many important inputs, and this documenting all those discussions and tabling to the Ethiopian National Immunization Technical Advisory Group would be needed. Support, follow up, monitor, and evaluate the hepatitis pilot implementation will be our tight task because it will stay for a year. So we have already tested for 2 to 3 months. Actually, the 3 out of the 4 districts have started on February. So we will remain with 10 and around 9 to 10 months to do this task. Engaging and collecting the best lessons and experiences from other low and middle income countries on top of the generating the data from the pilot implementation is another activity that we will engage. Engaging the Ethiopian National Immunization Technical Advisory Group to undertake rigorous review of the evidence from the pilot implementation and the other evidence sources will be vital to draw an independent recommendations. This NITAG is very responsible to come up with technical guidances for the ministry, and then the ministry will call the members of inter-coordinating committee. This inter-coordinating committee is a member of all partner heads chairing by the Minister of Health, the State Minister, and then this ICC will discuss and make final decision on the national universal introduction, hepatitis birth dose introduction. In case this ICC make decisions, and then following this resource mobilization and application for Gavi support and other supports will be the next task that we are expecting. As a country, on behalf of the country, I want to call for networking, collaboration, and action, because this networking and collaboration matters to translate the targets of hepatitis elimination into realities, including ensuring high timely hepatitis birth dose and the required consecutive 2 to 3 doses coverage in countries based on the WHO recommendation. Then Ethiopia is very open to collaborate, network, and receive any supporters for the full-scale universal hepatitis birth dose introduction, as well as overall hepatitis prevention, control, and elimination efforts. So finally, last but not least, I want to say that let us join our sets of various resources to translate the national and global targets into reality for hepatitis elimination by 2030. I think, as we all know, we have a tough target to reduce the chronic hepatitis virus infection prevalence to a level less than 0.1%. So I think this needs our joint effort to realize within the set timeline. This is over. Thank you so much.
Great. Thank you very much, Mulat, and for that good presentation. I think we have a lot of lessons to learn from Ethiopia and Ghana now that they are making those initial steps towards vaccine introduction. They have also been able to pilot and get a feel of how it's going to work. I want to open up for discussion, and maybe you can start by discussing about NITAGs, the National Immunization Technical Advisory Groups. And this is probably to Mulat if you are online, and anyone else, including Ghana. I would like to understand what has been the role of NITAG in terms of the whole process of introducing this birth dose vaccine into the EPI program.
Thank you, Dr. Henry. Let me give a chance for Johannes Lakau. Johannes is a team lead in the Ministry of Health. I think he can respond on this regard because I have already made the presentations. I will give for my colleagues. There are colleagues from the Ministry of Health attending this meeting. Over.
Hello, Mulat. Can you hear me?
Yeah, go ahead, Johannes, we can hear you.
Thank you very much, Mulat. He's our staff member and is a technical assistant who are working on the hepatitis B Birth pilot in the country, and he was a former EPI manager as well. So I think this hepatitis B Dose network will be very helpful for our country as well as for other countries to learn experiences from other countries as well, to share our experience to other countries. Maybe I missed the questions raised by the colleagues.
I can repeat the question. Yeah, the question was about NITAG. What has been the role of NITAG when it comes to the whole process of introducing the hepatitis B birth dose in your country?
Thank you very much. NITAG have an advisory role for the ministry. So basically, they are experts and the scientists who are working on immunization and other areas. Basically, they will look at the strategies that will be feasible for our country and applicable. And they will see all the technologies that are going to be utilized, like the vaccine efficacy and other issues. So NITAG will basically advise us on the methodology and the approach and the strategies. So based on their recommendation, we will present to the immunization coordination committee, which is, we call it ICC. So the final decision will be made by the ICC for the introduction, and then we will go for application to Gavi for budget support and the vaccine support. So basically, the NITAG will basically support us on the technical advisory role.
Great. Yeah, thank you very much for those insights. Does anyone else have a question in the audience? I can give this chance to you. You can unmute yourself. We have Mulat and the EPI, Johannes from Ethiopia. If you have any questions, you can direct them to them for any feedback.
Well, Henry, I had one question about working with the maternal child health programs, the birth attendants, and how to get them to become vaccinators for newborns. As Dr. Achu said, not everyone likes more responsibility. Botswana gave some good examples of how hepatitis B vaccine is one of several interventions given at the time of birth. So, maybe perhaps making it working with the maternal and child health program that's already experienced in delivering an intervention early in life. So I was maybe had my question for Dr. Achu to help us understand how are you beginning to develop those relationships with the birth programs to implement hepatitis B birth dose? Is it a policy issue, a training issue, just education? And then what's the role of parent education, please?
And in case Dr. Atsu is not in this meeting, maybe Fred or Sei, I can see you are in Ghana. If you have any feedback on that question, I think that you can contribute to that.
Right.
Okay, thank you very much, Henry, and thank you for the question. Yeah, so in Ghana, there is a good collaboration between the EPI program and the Family Health Division, where Child Health Department sits. Occasionally, we do hold joint review meetings to look at some of these child health indicators. And of course, we appreciate very much that when we talk about a child, immunizations are not different from other essential childhood interventions. So we look at the child in totality and not per program. So that's one good thing that we are doing here in Ghana. When a child is born, so many things are done to this child, and I don't think introducing this birth dose will alter the current practices in the country. Of course, it was clearly shown in the presentation that provision has already been made in our home-based record, which we call the maternal and child health records for hepatitis B birth dose. In fact, this was inserted somewhere in 2018 when we started having this discussion of introducing a birth dose for hepatitis B. So from our side, it's not going to be an issue at all. In terms of the involvement of NITAG, it's been discussed at the NITAG level, and of course, my colleague from Ethiopia explained the role of NITAGs. Of course, their major role is to look at the evidence and advise the ministry, but the ultimate decision is taken by the Ministry of Health through the ICC. We have gone beyond that, but it so happened that in our application, we need to demonstrate that indeed we have an appreciation of the burden of hepatitis B in Ghana. And that's the more reason why we are conducting this seroprevalence study to establish the burden. And with that information, we'll go ahead and submit our application. So I don't know whether there are any other follow-up questions. I'm available to take them up. Over.
Okay. Thank you so much, Fred. That has been wonderful. John, you have anything more to add before you go to the next presentation?
No, thank you very much, Fred, for that extra information. I think let's move on to make sure we have plenty of time for the other presentations and discussion. Thank you.
Thank you. So Lindsay, if you can have the next set of slides up. So the next presentation is again a recorded presentation, and this is from our colleague from Togo, who happens to work here in the US. And we are fortunate that she is a nurse, chief nurse in the immunization program in Houston, Texas, and has been very keen about the hepatitis B birth dose. This presentation, we had to cut out some parts, but just to make sure that we fit within our schedule. So pardon us for that, but we will be sending the full presentation later on into our website, which can be accessed. And I think the details for that are already in the chat box. Thank you so much. Let's have this presentation.
Good morning, good afternoon, everyone, wherever you are on planet Earth. My name is Essie Havor, and I'm the chief nurse for the immunization program here in the Houston Health Department in Texas. It is my honor to share my experiences with you on improving hepatitis B birth dose coverage. I hope you find this presentation helpful. So these are my learning objectives. I plan to provide a very quick overview of the Houston perinatal hepatitis B prevention program, and then share with you our quality assurance approach to increase. See what I'm saying? And share some of the lessons that we learned through this. Highlighted. That's one thing. So just to give you a quick overview of the perinatal hepatitis B prevention program, is a national program here in the U.S. It was created in 1990 by the U.S. Center for Disease Control and Prevention. It's actually CDC Fund 64 U.S. jurisdiction throughout the United States and its territories, including Puerto Rico and Guam. Here in Texas, we have actually 3 CDC awardees, and Houston Health Department is one of them, also San Antonio and Texas. However, the Houston Health Department also received additional funding from the Texas Department of Health and Human Services to cover immunization activity in the Harris County area. So when I'm presenting this data, it includes also data from the Harris County, but also in Houston. So this is just a quick diagram to actually share with you the 6 responsibilities that we have as a program. However, I want to focus on one aspect of these responsibilities, and is the quality assurance program, which also include improving the coverage rate of hepatitis B birth dose. As you all know, in US, hepatitis B vaccination is recommended to all newborns that are medically stable, way before even 2018. However, in 2016, the recommendation changed from administering the hepatitis B birth dose prior to be discharged from the hospital to administration of the vaccine within 24 hours. And this publication actually came through in 2018, which we also use to educate our partners. So the main focus of my presentation, really, like I stated earlier, is the quality assurance method that we use to improve and sustain the hepatitis B coverage, those in the delivery hospital. So here in the Houston Health Department, I'm responsible of working with between 25 to 26 delivery hospitals. And part of the quality assurance visit that we conduct in all these delivery hospitals actually occur every other year. So for example, the last one we conducted was 2018, and we were getting ready to conduct the next one in 2020 when the COVID-19 hit. So this assessment is actually 2-part assessment. The first one is the policy practices survey, where we actually send a link or a paper-based format survey to the key leaders of the labor and delivery hospital to make sure that they share with us their written policy, their standing orders. Some of the questions we ask them include, the documentation of the hepatitis B birth dose, and also if they part of the quality improvement or indicator that they use to measure the hepatitis B birth dose in the hospital. The second part of the assessment includes the medical record abstraction. So we actually provide detailed instruction on how to pull the record. So we ask them to submit a certain number of records to us. And from there, we actually pull randomly the record that we want to review. And then we send the record back to the hospital so they can give us access to the record. Part of this assessment, some of them we do it, remotely, so where they give us access to actually conduct the record review from the health department. Others, we have to actually go on site to use their computer to conduct the review. One thing that I want to say here is always mother-baby pair record that we review. So once they provide the mother's record, they also have to provide the baby's record so we can, review the record just to make sure that the documentation is there, and also, if they refuse the vaccine or the reason why they refuse the vaccine. All these assessments actually are conducted using the Centers of Disease Control and Prevention tool that have been developed for years. We just modify it to meet our need. And the survey also includes things like, if they test for HIV, if they test for maternal rubella, and so forth. So from the assessment,
Thank you very much. We have to cut that presentation short, but just like I mentioned, that presentation is available. You can look at the chat box there to be able to access the full presentation. We have very good lessons from that, so I would encourage you to look at that. The next session is going to be now the southern part of Africa, the country South Africa. We have two presenters who are going to share their experiences with the hepatitis B birth dose vaccine. We have Dr. Nishi Pradhyal Singh. She is a principal scientist and virologist at the National Institute for Communicable Diseases in Johannesburg, and is a member of the technical working group of the viral hepatitis guidelines with South Africa National Department of Health. Let's hear her recorded presentation, and she is also available in this meeting for questions. So hold your questions, and I encourage you to type any questions that you might have coming up in the chat box, and you also have the opportunity to ask them to her after this presentation, after the next presentation. Thank you.
Good morning, good evening to everybody. Thank you to the organizers for the opportunity to present some data from South Africa. So the presentation will be done in two parts. I will be discussing the hepatitis B review of data, and Dr. Khomotso Vilakazi will be presenting on the guidelines and action plan. So I am Nishi Pradhyal Singh from the National Institute for Communicable Diseases. So this is a map of South Africa showing you the 9 provinces, and also showing you the density for each province. So the lighter shades showing you very sparsely populated provinces, and the more brown or reddish shades showing you the densely populated regions of the country, like Gauteng. The population of South Africa is approximately 59 million. The average number of children born per year is approximately 1.1 million, and there's an estimated 90% hospital births. The vaccine, hepatitis B vaccine, was introduced in 1995 in our expanded program on immunization. The vaccine coverage for our BCG dose at the moment stands at 86%, and our third dose HepB vaccine for 2020 was around 84%. So just to remind you that the hepatitis B transmission risks in South Africa are usually four ways, and the first one is horizontal transmission. So that means children younger than the age of 5 can transmit the virus from one child to the other. And that was our most highest transmission risk in the country. And the reasons for that was the lower prevalence of E antigen positivity in mothers before the HIV era. And also it was, presumed that children are coming to close contacts, contact with household people, adults who had hepatitis B, and also they scratch and fight with other toddlers and younger children and transmit the virus early on in childhood. The second transmission risk is through perinatal, and this had an impact on the HIV HBV co-infection in pregnancy, where pregnant women who are HIV positive are 3 times more likely to test positive for DNA, for HBV DNA with higher HBV DNA viral loads. And they're twice as likely to test positive for E antigen. And there's an increased risk of mother-to-child transmission with 90% risk of chronicity in children. When baby is born to Hep B positive moms. Sexual transmission, obviously adults born before they had the vaccine, that's pre-1995, can transmit by sexual means, and percutaneous transmission like needle stick injuries in healthcare workers. So I am presenting data from studies in South Africa. So South Africa has a very rich history with hepatitis B, and dating back to 1980. But in the more recent surveys that are taken place in the country nationally, some of the data that comes through showing here larger sample size, showing HBV surface antigen prevalence in adults ranging from 3% in HIV uninfected individuals to around 8% in HIV infected individuals. Just to bring your attention here, that a lot of these studies are using samples from other surveillance groups, and that's quite novel, and it's quite interesting to see the data that's coming out, from KwaZulu-Natal, for example, on the Caprisa AIDS treatment program, as well as the HIV incidence provincial surveillance system. Hepatitis B surface antigen prevalence in children. Again, if we compare unvaccinated children from the 1999 study done by Vardis, she showed a high prevalence of 10.4% in unvaccinated children. And in our recent studies, we are showing 0.4% HBs antigen prevalence in the recent studies. However, some of the sample numbers are smaller, and I will show you now data from our 2019 study, where we see that in a 0 to 4 age group, in national passive laboratory surveillance, you can see detection rates of positive cases in the 0 to 4 year age group is about sitting at 3.3%. And that just shows that hepatitis B virus is still present in the younger age groups. And collectively, if we look at from the 0 to 24-year-old age group, we are reaching around 13% positive cases tested for HBs antigen. So it just shows that we still have a problem in South Africa, especially in those individuals that should have been vaccinated. And then this is recent data coming out again. This is a publication that's due to be released. It's from 2015 to 2019, collective data showing you in the age group 0 to 4-year-old, there's quite a few positive cases. And if you look at the blue bars, they're showing you in the region of, in the age group 0 to 1 year, that's the number of positive cases per province is quite prevalent. So once again, we can see that in the 0 to 1 year age group, we're still having an issue with hepatitis B. So I've summarized the data very quickly from as early as 1999 to our present studies. There is known evidence, as I've presented, that the gains of Hep B vaccination in South Africa has been largely felt when we compare data pre-1995 and post-1995. The data provided that there are still cases of hepatitis B infection in the country in the age group that should be protected. And this could be due to poor vaccine coverage, mother-to-child transmission is taking place, and this is concerning data that shows that in the 0 to 1 year age group, there's quite a high prevalence in those age groups. And of course, vaccine hesitancy is something that we need to address. In order to curtail some of these, we have to roll out programs introducing the birth dose in the country, screening all antenatal women in the clinics for hepatitis B, and of course, follow up the mom and child pairs. Thank you. I will now hand over to Dr. Vilakazi.
Great, thank you so much. So the next presenter is going to be Dr. Vilakazi Nlapo, who is a viral hepatitis lead at the National Department of Health. This is also a recorded presentation, so let's listen to it.
Good morning, good afternoon, good evening, colleagues. I'm Khumuto Vilakazi Nlapo from the National Department of Health in South Africa. I'll be presenting on the National Clinical Guidelines and the Hepatitis Action Plan for the country. The guidelines and the action plan were approved in 2018. In the action plan, we've got 5 priority areas. The first one is to raise awareness of hepatitis viral infection amongst healthcare workers and the general population, as knowledge and information on viral hepatitis is very limited in these 2 groups. The second priority is to strengthen knowledge of hepatitis burden of disease. Currently, we have no existing surveillance system in the country. Third is prevention of transmission of viral hepatitis through education, vaccination, diagnosis, and treatment. Number 4 is to improve our diagnostics and treatment for chronic hepatitis infection. And number 5, of course, is to have a coordinating office. As part of the action plan, obviously, we have priority interventions. This is the first national guidelines and action plan for the country. And due to issues of resources, so we had to prioritize even interventions. One of the priority interventions is the implementation of the hepatitis B birth dose vaccination. Currently in our EPI, we've got the HepB vaccination at 6, 10, and 14 weeks with a booster at 18 months. So the priority is to introduce a birth dose vaccination within 24 hours of birth. The other priority intervention is to ensure that all our pregnant women are screened for hepatitis B, and those who have a viral load more than 200,000 and hepatitis B surface antigen positive will be given tenofovir in the 3rd trimester. Tenofovir can be stopped 12 weeks post-delivery if it was only used for mother-to-child prevention in HIV-negative pregnant women. Our HIV, TB, STIs, PMTCT guidelines, and our maternal care guidelines also include hepatitis B birth dose guidance. We also have, as a priority intervention, a one-time campaign to screen all our healthcare workers for hepatitis B and hepatitis C, and to vaccinate those who are eligible. We did costing of the birth dose implementation as part of our action plan. We did costing for vaccines and consumables, the additional cold chain and dry storage needs that may be needed, the expansion of vaccine distribution size, the distribution costs, training of healthcare workers, waste management costs, development of communication strategies, the IEC materials, revision of our records, registries, and etc. And obviously, we do have implications for our EPI schedule with the introduction of this vaccination. As I said earlier, we prefer to administer the HepB birth dose within 24 hours of birth, followed by at least 2 subsequent doses. And in the interest of access and public health as a country, we have opted to do a complete rollout. That is, all newborns will be offered the birth dose. Evidence from observational studies have shown that birth dose vaccination can still be effective against perinatal transmission, even if given later than 24 hours after birth. We know that even though we have a very high facility births. We still have women who give birth outside the facility. So the catch-up will be provided up to 2 weeks after birth. Access for infants who are born outside facilities is still being discussed. We will also like to include the birth dose in the private EPI schedule. Discussions are also ongoing for that. We have revised our maternal care guidelines to include the birth dose. Our implementation activities also include the situation analysis of our EPI program. We need to ensure that our national policies also support implementation of the birth dose vaccine. Our health facility policies and procedures also require and authorize appropriate staff to give the birth dose. And we also need to ensure that the private sector do provide the birth dose and that they have access to vaccines. We, of course, will train all appropriate staff working in immunization and maternal and newborn health to ensure they know how and when to give the birth dose. We'll supervise and monitor at all levels, that is national, sub-national facility levels, and all other settings where births take place, whether it's public, private, or in the community. We have to actually also ensure that our regulatory authority does register the birth dose, because now it's only registered for the other ages. We've also written a submission to our Director General for a change of the EPI schedule to ensure that the birth dose is included in our essential medicines list. We've also started a submission to ensure that the next national indicator data set has got HepB birth dose indicator so that we can be able to monitor the program. This program will be coordinated from the National Department of Health. Stakeholder mapping was done with other programs, including HIV/TB, maternal health, primary health care, and district health services. We have also identified other stakeholders that were also invited, like the private sector, community forums, or other interest groups who will assist us in the implementation of the birth dose. The project plan has been done after a stakeholder analysis, and the lead persons were identified for the implementation of each activity according to their expertise. We plan to do post-implementation evaluation 1 year after implementation. Unfortunately, the implementation of this project has been delayed due to the current ongoing pandemic of COVID-19. Thank you.
Thank you so much, Motso and Nishi, for that presentation. I think one important finding is that despite the relatively high coverage for hepatitis B third dose, the third dose that is given with Penta being very high, we still have a very significant number of children who are hepatitis B infected, meaning that there's a potential for the effect of birth dose in preventing some of this transmission. I want to maybe see whether there are any questions that that can be discussed in this at this juncture. If you have any questions, please do let me know. Otherwise, we can proceed to the next level. But before then, I think John, you have any discussion around that?
Well, I was interested that the BCG coverage was 86%, but there seemed to be, some lack of timely birth dose vaccination. Again, this mention of, providing the vaccine up to 14 days after birth, and then considering that birth dose, which really greatly weakens the protection that vaccine provides to interrupt mother-to-child transmission to very little protection. So I was curious if they had information about what's the timing of BCG vaccination and again, opportunities to provide that hepatitis B vaccine sooner, so it'll be maximally protective for the infant. Thank you.
Anyone from South Africa can respond. Nishi, Motso.
Good afternoon, good morning. I thank you for the question. I hope I'm audible. The information we have with BCG is that the vaccination is usually given before the mother and child care leave the hospital, which is within 3 days.
If you can speak up a little bit, Motso, we can hardly hear you. That would be helpful.
Hello, can you hear me now?
Much better, thank you.
Oh, okay. Yes, I just said the information we have is that the vaccination, the BCG vaccination and polio is given when the mother and child pair are discharged from the hospital or the clinic, which is usually on day 3. We do not have any, documented information to indicate when is the bulk of the people vaccinated, whether it's within 24 hours, 48 hours, or 3 days when they leave. I think that is something that we will look at.
Okay.
We will, of course, take advantage of the fact that BCG and polio are given after birth to ensure that birth dose can also be added to that. We have actually been informing our healthcare workers as we train them on the guidelines that we will not employ midwives, especially, or nurses or any other staff just for birth dose vaccination. So the midwives or whoever does the birthing process will have to also do a birth dose vaccination. Thank you.
Thank you very much. It's very, very helpful. I think, Henry, one thing I'd like to do, I know we're very late in the program, and it's a little bit, we can take a little bit of a mental break for a moment and get a group photo of the meeting. At this point, I know we're almost at the conclusion, but sometimes I worry if we go over, we won't be able to capture all the rich representation we have on this meeting. So maybe Lindsay can advise us, but if everybody can turn on their camera for a moment for a group shot, we will appreciate it, and of course be able to share it with everyone. So Lindsay, what would you like for us to do?
Sure, if everyone could just turn them on, and we have so many participants, we'll have a few pages, so if you don't mind smiling for about 15 seconds, I'll just scroll through the different videos.
Yeah, please turn on your screens and
Great, thank you. All right, I did page 1.
Are you seeing plenty of screens?
I am, yes.
Okay.
Everyone looks fantastic. Okay, do one more. Okay. Wonderful. Thank you, everybody.
Thank you very much.
Okay, wonderful.
Right.
Thank you so much. So the next presentation, Lindsay, if you can share your screen, is going to be from Mozambique. Again, we are in the south, so we have tried to make sure that we have most of the countries represented. And this presentation is going to be presented by Dr. Helga Guambe, who worked at Magude district in Mozambique as a medical chief doctor, and is currently the PMTCT focal point person at the Ministry of Health in Mozambique. She's going to present this, and this is a recorded video. And after her presentation, we'll have the Mali presentation, and after that, we will have question and answers. So let's listen to her presentation.
Hello, everyone. Thank you to Coalition for Global Hepatitis Elimination for organizing this exciting meeting and for giving me the opportunity to give an overview of the hepatitis birth dose introduction in Mozambique as part of the PMTCT, highlighting the main gaps. So my name is Helga Guam. Doctor, I work at the Ministry of Health and I am the PMTCT focal point. So Mozambique is a country with 30 million people. We have 391 maternity wards. Our fertility rate is 5.3%. The first ANC coverage is 115%, and the fourth ANC coverage is 58.5%. In 2020, we had over 1 million live births, with 85 of those that were institutional deliveries, and the prevalence of HIV among people of 15 and 49 years is 13.2%. The HBV vaccine is available in our country since 2004, and it's a part of the immunization schedule for all children. In 2020, the OPV and the BCG vaccines, they are over 100%. The DPT1 and DPT3 were also over 100%, and this is due to our denominator estimatives issues. The hepatitis B birth dose is not provided yet in the country. It's been approved by the National Immunization Committee to be implemented in the country, and it's also part of the national plan for the triple elimination of vertical transmission of HIV, syphilis, and hepatitis B. Despite limited data, prevalence of HBV in Mozambique is thought to be high. Among general population is 7.2%. Among women of reproductive age is 10%, and among ART naive HIV positive is 7.6%. According to a study conducted in a youth clinic in Maputo, they had 12.2% of HBV prevalence among median age of 16.6 years people. So this is our hepatitis B and C protocol, clinical protocol. And our national policy is to screen all pregnant women in the first antenatal visit, preferably in the first trimester of pregnancy. It's important to say that in our country, we are not yet implementing any activities for the PMTCT of hepatitis B. This is something that we are working very hard to introduce in the next few years. So still in this protocol, we have some guidelines for treatment. And for the co-infected pregnant woman, HBV and HIV co-infected pregnant woman, we will give them our first ARV line, which is TDF, 3TC, and DGG. The HBV mono-infected pregnant woman will be evaluated for eligibility to start antiviral prophylaxis with TDF. This will be done from the 28 weeks of gestation, or they will be evaluated to get the treatment with TDF or entecavir if necessary. In this slide, I'm showing you our national PMTCT triple elimination plan. So here we have some activities or objectives that we want to aim, which is to integrate in implementation this plan, which is to integrate the birth dose of hepatitis B into the national vaccination schedule, to start the HBs antigen testing at ANCs, to assess co-effectiveness in the context of Mozambique, on the use of antivirus to prevent HBV transmission, and to integrate the hepatitis B indicators into our monitor and evaluation system. So here, I'm gonna be talking a little bit about the implementing research that was done in Chamangul ANC and maternity. And the strategy was to prevent hepatitis B vertical transmission, focus on use of tenofovir for pregnant women and introduction of birth dose. And these strategies were considering that Mozambique is a low middle income country with high transmission of HBV. There are patients who need hepatitis B treatment following WHO recommendations and are not receiving it. Hepatitis B vaccine birth dose is not included in national immunization schedule. And it's important to say that these activities, they were done at one-stop model at health facilities using the nurses that are working at those consultations. These are the activities that were integrated into the ANC services, into maternity services, all the MSH services using our nurses that are working at those consultations. Was the hepatitis B testing during antenatal care, the hepatitis B treatment and prophylaxis for pregnant women if needed, and the hepatitis B newborn vaccination at maternity, and testing partners and children for HBs antigen positive pregnant women, and hepatitis B vaccination if needed. See, these are some data that we managed to collect from November 2017 to December 2020. 11,807 women, pregnant women, they were screened for HBs antigen. And of those, 7,288 that were negative, they managed to get all doses of the HBV vaccination. So the ones that were tested positive, we had 420, and of those, 35% were HIV co-infected, and we had 3.5% of positivity rate. The ones that were HBs, antigen positive, they were screened for HBe antigen and for viral load. After that, some of them, they had indication for TDF, and the others, they had indications for TDF prophylaxis, and the other ones, which was 138, they were doing the TDF as part of RT first line in the country. So the babies that got the hepatitis B birth dose, we had 8%, and the final status of the maternal and child transmission was less than 1%. So the achievement and challenges of implementing this research was that the HBs antigen rapid test was integrated, as we have said before, together with the HIV and syphilis rapid test that is done at ANC. HBV positive mothers, they were referred to MSF team for HBE and viral load, since these are the tests that we don't have in the country yet, but they managed to implement it in this research. And the challenge was to have these tests available at all ANC. The HBV birth dose vaccination was integrated in postnatal. Unfortunately, the babies that were born out of these maternity, they didn't receive this vaccine. So the challenge is to have this birth dose vaccine at all maternities. The follow-up after delivery was difficult, as mother and babies are followed by other services, and then they had to go to the maternity just for the HBV consultation. This is the thing that they didn't manage to integrate. It was this follow-up of the baby mothers at the routine consultation. This was one of the things that they didn't manage to integrate. Regarding the tools, they managed to adapt by adding stamps for testing and vaccination on our registers that we have now. So it was not a challenge for them to register the testing and the vaccination. Our next steps is to follow up with global funds for acquisition of rapid tests of HBs and HBV antigen, acquisition of TDF for prophylaxis and treatment, to follow up with national immunization program, for submission of the proposal for financial request to Gavi, to develop national clinical protocols for implementation of PMTCT for hepatitis B, and last but not least, the revision of our MCH monitoring and evaluation tools to integrate hepatitis B indicators and variables into this register. Thank you very much.
Thank you very much. I think that was a very clear presentation. So the next one that you're going to have, we are going to move from south to the northern western part of Africa. We are going to have a presentation by Mamadou. Mamadou Keita is a specialist and researcher in infectious diseases and tropical diseases. He's also the founder of the Malian Society of Infectious Diseases and Tropical Pathology. He has been involved in a lot of work on viral hepatitis, including HIV and AIDS, with the Ministry of Health and Social Development in Mali. Dr. Mamadou is going to present live, so we are going to have a live presentation from Mamadou, and his presentation is going to be in French, but you will be able to listen to the translation for this particular presentation. After his presentation, we'll open up for discussions. So be ready with your answers. Again, continue posting them in the chat box. I have seen a few, and I want to encourage you to continue doing that. So Mamadou, be ready with your presentation and take it off from now.
Oui, je suis prêt. Je suis prêt. Je partage mon écran ou vous allez projeter, sinon je peux partager mon écran. Tu peux me déchirer. Voilà. Est-ce que vous voyez mon écran?
He's wondering if you want him to share his screen.
Yes, please. Yes, he should share his screen, please.
OK, allez-y, présentez, allez-y, Dr. Keita.
Vous avez
on ne le voit pas d'abord. On ne voit pas d'abord l'écran.
OK. Sinon, vous pouvez projeter, je vais présenter directement sur... C'est bon, vous voyez maintenant?
Voilà, c'est bon, c'est venu. Maintenant, vous pouvez peut-être mettre ça en mode présentation. Merci.
OK. C'est bon maintenant?
And for the listeners, I would ask you if you're
bon?
English. Sorry, we need to provide instructions about how to go along translation. If you are an English speaker, go to the bottom of the screen, there's interpretation, and click on the English section so that you can be able to follow this presentation. Go ahead, Mamadou.
OK, merci. Merci. Bonjour à toutes et à tous. Et merci aux organisateurs et particulièrement à Harry, on a eu beaucoup d'échanges pour cette présentation. J'ai le plaisir de vous présenter un peu l'introduction du vaccin contre l'hépatite virale B au Mali. Je suis Dr Mamadou Keita au niveau de la cellule sectorielle de lutte contre le VIH-Sida, la tuberculose et les hépatites virales du ministère de la Santé. Et donc, je vais partager avec vous la situation du Mali. Donc, concernant la couverture du vaccin au Mali, et par rapport au nombre de naissances, le Mali enregistre près 582 000 naissances par an, le cas en 2018. Et parmi ces naissances, il y a 74% qui sont faites en milieu de soins, qui sont assistées, des naissances assistées. Et il y a un quart qui est fait en dehors sans assistance d'un professionnel de la santé. Et pour les objectifs en termes d'atteinte de la couverture vaccinale, particulièrement avec les pentas, comme je disais en début de mon introduction, le Mali n'a pas commencé le vaccin monovalent pour l'instant contre l'hépatite B. Donc la couverture de l'hépatite en penta 1 est de 108% et la penta 3 est 95,19%. Mais il faut dire qu'il y a des disparités entre les régions. On prend certaines régions du centre et du nord où les proportions n'atteignent pas l'objectif fixé par le programme élargi de vaccination au Mali qui est de 95%. Donc les régions du Gao, Ségou, Mopti et Taoudéni sont à moins de 95% en penta 3. Voilà un peu ce qui illustre un peu cette carte illustre cette couverture en penta 3 dans le pays qui est de 105% à Bamako et comme vous pouvez le constater à 22% dans la région de Kidal. Nous avons 10 régions au Mali et la capitale du pays. Donc ce qui fait 11 au total. Par rapport à la prévalence de l'hépatite virale au Mali, il faut dire que nous n'avons pas de données de façon nationale dans le pays, mais nous avons des petites études qui ont été réalisées surtout en milieu hospitalier, qui donnent des prévalences qui vont de 12% à 24%, parfois au-delà en fonction des études. Mais il faut dire que c'est des études qui sont faites au niveau hospitalier. Mais au niveau du programme de lutte contre le VIH et la tuberculose, rappelez que le Mali a intégré la lutte contre le VIH, la tuberculose et les hépatites virales. Donc, nous avons l'année dernière fait des campagnes de dépistage qui nous a donné 7,2% dans les zones concernées. Ça a été fait dans 3 régions du pays, plus la capitale. Et au cours de cette campagne, nous avons constaté 27,27% de prévalence de l'antigène HBS chez les femmes en âge de procréer. Donc, ce qui est préoccupant pour nous parce que les femmes en âge de procréer, il faudra qu'on puisse les suivre pour éviter la transmission de la mère à l'enfant. Donc, la prévalence chez les femmes enceintes, parce que cette campagne a concerné aussi les femmes enceintes, allait de 5% jusqu'à 12% dans les régions. Et concernant les enfants de façon spécifique, les moins de 5 ans, nous n'avons pas de données nationales et concernant les enfants parce que, comme je le dis, c'est le programme de lutte contre les hépatites qui a intégré la lutte contre le VIH et la tuberculose a été créé il y a juste 2 ans, en 2019. Donc, concernant la prévention de la transmission de la mère à l'enfant, ce qui est fait actuellement au Mali est que les femmes enceintes sont dépistées lors des consultations prénatales. Le dépistage est systématiquement proposé aux femmes enceintes lors des consultations prénatales. Et les femmes qui sont positives au marqueur de l'hépatite B sont screenées et mises sous traitement. Mais malheureusement, au Mali encore, ce traitement est supporté par les malades, les tenofovir, le TDF qui est donné et qui est au prix subventionné de 5 000 francs, soit $9 américains. Concernant la vaccination des nouveaux-nés qui sont nés de mères positives à l'hépatite B, ces enfants sont vaccinés immédiatement à la naissance, mais c'est à la charge des parents parce que ce n'est pas encore supporté par l'État et ses partenaires. Alors, par rapport au processus d'introduction, nous avons des données, la nécessité de collecter des données parce que nous n'avons pas encore de données bien centrées au niveau du pays. La centralisation des données n'est pas encore OK, les données sont par endroit. Et le programme qui a été créé en juillet 2019, dont je travaille, chargée de coordonner ces activités-là au niveau du pays. C'est une structure qui est rattachée au ministère de la Santé. Nous avons à ce moment précis des manques d'outils de collecte des données primaires, parce que les autres maladies, on a des outils primaires qui peuvent nous permettre de collecter les données. Ce n'est pas encore le cas pour les hépatites virales au Mali. Nous sommes en train de travailler pour élaborer ces documents normatifs qui vont nous permettre de collecter les données et d'avoir des données tangibles, des données qui puissent nous permettre de donner les vraies prévalences et les vrais cas de l'hépatite virale au Mali. Et l'élaboration de ces documents est soutenue par l'Organisation mondiale de la santé, je veux dire, pour nous aider avec un consultant pour faire ce travail. Par rapport à l'analyse des données, elle reste parcellaire par endroit. Certains centres font la bonne compilation et arrivent à donner les sommes, mais ce n'est pas partout dans le pays. Et nous avons aussi une faible implication des parties prenantes, ça il faut aussi le noter. Et ça, nous sommes en phase de plaidoyer pour avoir l'adhésion et l'accompagnement de tout le monde dans la mise en œuvre, autant au niveau national qu'avec nos partenaires multilatéraux et bilatéraux. Et nous prévoyons dans ce cadre-là de solliciter Gavi. Nous avons eu des échanges au niveau national, le Centre national d'immunisation en particulier, des échanges avec Gavi pour l'acquisition de vaccins monovalents, bien sûr, et nous avons des échanges avec l'OMS. Et le Rotary aussi nous appuie, nous comptons sur ses partenaires pour pouvoir nous aider à aller vers l'introduction du vaccin à la naissance. Par rapport aux défis, comme je disais tout à l'heure, nous avons des manques de données qui puissent nous sur la séroprévalence. Également, les problèmes de fonds se posent également. Comme vous le savez, le Mali est un pays qui est actuellement en crise sociale, sécuritaire et même un pays qui est en transition politique également. Donc, nous avons des difficultés financières et aussi, nous n'oublions pas aussi l'impact de Covid et la situation sécuritaire de notre pays qui nous impacte également. Alors, malgré cela, quand il y a des opportunités, c'est que au niveau du pays, le système, l'administration des vaccins est bien coordonné parce que nous avons un centre national de vaccination, un centre national d'immunisation, on l'appelle ainsi, qui est chargé d'assurer la vaccination. Et c'est là, dans toute l'étendue du pays, ce qui fait que les couvertures que nous avons est obtenues grâce à ce système d'administration des vaccins. Et également, nous avons aussi la possibilité de faire vacciner les enfants tant bien dans les centres de santé que dans la communauté, parce qu'en matière de vaccination, l'hépatite virale n'est pas une maladie qui est accompagnée de beaucoup de considérations culturelles. Les gens le comprennent parce que sur le plan, dans nos habitudes, la maladie est connue sur le plan dans nos traditions. Donc, il n'y a pas beaucoup de problèmes de stigmatisation ou de refus de vaccination par rapport à l'hépatite B. Mais bien naturellement, des confusions peuvent avoir avec d'autres problèmes de santé. Donc, nous avons également l'opportunité d'impliquer des partenaires parce que nous avons eu des échanges avec eux. Donc, c'est une opportunité pour nous aussi de pouvoir les impliquer dans cette démarche pour pouvoir introduire le vaccin monovalent à la naissance. Et également l'opportunité d'utiliser les données, mais nous sommes en train de chercher à faire une étude de grande envergure pour qu'on puisse avoir une bonne prévalence de différents marqueurs de l'hépatite, surtout l'antigène HPS dans la population, surtout les enfants. Et c'est vrai, les données que nous avons actuellement, qui sont des études ou de l'hôpital, ne permettent pas de parler de façon nationale, mais nous avons en vue quand même de pouvoir faire des études plus larges pour avoir des données qui puissent nous permettre d'argumenter notre démarche. Voilà sur ces mots que je vous remercie. S'il y a des questions concernant le Mali, je reviens quand même pour dire que le Mali n'a pas commencé le vaccin à la naissance, même si ça avait été introduit et interrompu. Le vaccin est fait actuellement avec d'autres vaccins dans le Penta et qui est fait, comme vous le savez, à 45 jours de vie. Donc, notre souhait est que les démarches que nous avons fait actuellement pour avoir tout ce qui est documents normatifs vont nous permettre d'avoir d'ici la fin de l'année, en tout cas très prochainement, les différents arguments pour aller l'introduction du vaccin monovalent à la naissance, mais aussi nous comptons sur l'appui de nos partenaires et l'expérience des différents pays qui sont en train d'intervenir, et également la coalition pour nous aider dans notre démarche, parce que nous venons de commencer ce travail-là. C'est vrai que la lutte contre les hépatites a toujours été le problème de l'État malien, mais d'organiser un programme, c'est il y a 2 ans. Donc, sur ce moment, je vous remercie.
Excellent. That was very nice, Dr. Mamadou. We have been able to listen to you. Just as a follow-up, before we open it up, you've talked about data and getting data that will be able to tell about the burden of hepatitis B, especially amongst children. The question I have is that, do you have any programs that have collected blood samples and those samples have been archived? For example, the HIV program does a lot of work evaluating and they do collect nationally representative samples. And I don't know whether you have that within your healthcare system, that data archived somewhere, or rather those samples archived somewhere, which can be used for that particular exercise.
Oui, il y a des échantillons qui sont collectés, transportés, mais ces échantillons ne sont pas archivés, c'est-à-dire que ce n'est pas une banque d'échantillons qui est conservée pour de tels travaux. Donc, nous n'avons pas ça au Mali, malheureusement. Sinon, ça va nous permettre de faire une étude rétrospective pour avoir des informations. Mais là, nous sommes obligés de faire une étude maintenant pour pouvoir avoir des données assez tangibles. Donc, c'est cela. Nous n'avons pas une banque d'échantillons qui peut nous permettre de faire ce travail-là. Les échantillons sont utilisés et sans être archivés. En tout cas, concernant ces pathologies.
Okay. Thank you for that. And just another follow-up is about NITAGs, the National Immunization Technical Advisory Group. Do you have a NITAG in Mali, and how has it been engaged in terms of looking at data to make a recommendation for the birth dose?
Oui, nous avons un groupe consultatif sur la vaccination de façon générale. Ce groupe travaille avec le Centre national d'immunisation et le ministère de la Santé. C'est un groupe qui oriente, qui guide tout ce qui est orientation sur les vaccinations. Nous avons ce groupe-là, mais comme je le disais tout à l'heure, le programme spécifique par rapport aux hépatites, c'est vraiment quelque chose qui est assez récent. Donc, nous sommes en train d'intensifier tout ce qui est action à l'endroit dans la lutte contre les hépatites. Maintenant, on va prendre l'expérience des autres pays concernant les NITAC, les actions qui sont menées dans la lutte contre l'hépatite. Merci.
Thank you so much. So I'll open it up for more discussions. So feel free to unmute your microphone and we can continue discussions. So you have Mozambique having presented to us in South Africa, and I believe Ethiopia too and Ghana are still represented here. In case you have any questions, I think this is a good time to ask those particular questions. Over to you, John, if you have any discussion points.
No, just to see if there's anybody else raising hands. I know we're very short on time at the moment, so just want to make sure we get comments from others out for others to see.
John?
Yes.
Sorry, this is Antoinette, UNICEF SRO. I'm sorry, I could not figure out how to raise my hand, if I may.
Absolutely, please.
Thank you. Yeah, first of all, thanks for organizing this very, very useful webinar and for inviting us, and really a great big congratulations to all the presenters. These were really great presentations and very useful insight from the countries. I just have a couple of comments, reaction, if you wish, and a question to everyone. Actually, all the presenters actually have pointed out to the fact that really for this to happen, we need cross-sectoral collaboration, mainly API and the maternal and newborn program, ANC post-natal care as well. And it is also very important that we realize that the vaccinator role, delivery of the vaccine should be now delegated to the nurses. The vaccination has to happen in the ward room before discharge. Although, if I remember well, the SAGE recommendation says that ideally the vaccine should be administered within the 24 hours, up to 2 to 3 days, and 7 days is acceptable somehow, but that's not, it's just if there is no other options. But anyway, for the effectiveness of the strategy, the vaccine has to be delivered in while the mother and baby mother pair is still there. So there is really a need to collaborate with the API on that, not only for the delivery, but reporting. Hepatitis B coverage will be done by the API program. So just because of that, also the collaboration, cross-sectoral collaboration is important. On the role of the NITAG, that was something that came several times. I believe the kind of evidence the NITAG will require will not only be on the burden of the disease in terms of seroprevalence of the hepatitis B, of the antigens E, B, E, or the prevalence of the disease. But what they will be certainly looking at is the feasibility, the acceptability, as the colleague from Ethiopia has mentioned it, and the lessons learned from the pilot study, really assessing the acceptability of that intervention is very important, and that I believe that's what the NITAG will also want to have evidence on. So my question is, which kind of support countries will receive to really assess this feasibility, the programmatic implication of introducing the vaccine, because the WHO recommendations, the SAGE recommendation is pretty clear, but how to implement it and how to implement it in context where maybe the health delivery in health facility is not that high. So which kind of support countries can have from the global, this global initiative? Over, and thank you.
Thank you, Antoinette. I'm going to give others opportunity to speak. If we can't capture your raising hands, which is under reactions, just please speak up. Any other thoughts? Yes. Please. From Botswana.
Yes, as a follow-up of the same question on the kind of support that we can get. It's been a long time now with us trying to really work with WHO to integrate perinatal health issues. And Botswana has really struggled with trying to reduce our neonatal mortality and also our maternal mortality. We did not attain our MDG targets. So this is an area where we are really interested in getting some sort of technical support on how to really do this, not just the birth dose, but improve the quality of care and empower our midwives because all the vertical programs are demanding them to do different interventions for different. So we need an integrated approach and a support system for the midwives, and especially because we are having very high mortalities for the neonates. This is something that we will need substantial support. But we're an upper middle income country, and we don't get Gavi funding, we don't get much support globally. But I think the fact that we failed to attain our MDGs is saying a story that we really do need global support and technical assistance on really how to practically get things done. Because the data is showing that you're almost there, but we need on the ground implementation science to really make sure that we can achieve this very tangible goal of hepatitis elimination. Thank you.
Thank you very much for bringing out the importance of bringing it together as a comprehensive package for maternal and child health. Any other comments, please? This is very helpful to everyone. See, we have a little bit of a gap here. Rania Tuame, we haven't heard from you today from US CDC. Do you have any comments at this point? Otherwise, I'll be closing in just a few moments.
Yeah, thank you, John. I really congratulate all the presenters. It was really nice to hear the country experiences, their challenges, their successes, from various countries, those that have introduced the birth dose and those who are planning to introduce and how they plan for the introduction. So it was really kind of enlightening and very nice presentations from all the presenters. The main kind of themes that came up across all these presentations today is that mainly like for the health facility birth, first, you really need to have good integration between the maternal child health program and the EPI program. And that's key, and it's well known for birth dose vaccines. Hepatitis B birth dose, unlike the other EPI routine immunization vaccines where they're given, in the immunization clinic or outside of health facility, is kind of quite special, especially being a timely kind of, be required to be given within 24 hours of birth. So it requires this kind of strong coordination and collaboration across programs. That has been shown to be kind of the success story of many of the countries that have achieved high coverage. They've integrated HepB birth dose as part of the MCH and EPI working together. The second kind of challenge that I've heard from is the home birth and how do we reach those children who are born at home. And it is very challenging to reach children who are born at home, especially when you're in a rural area, you have to work hours to reach a health facility. But some of the comments that I've seen in the chat and some of the other kind of interventions we've seen in other countries could be kind of piloted and checked whether they work in several African countries, such as we mentioned the linkage of community health workers or community volunteers, or engaging civil society. So these are kind of activities which could, one, increasing the awareness of the pregnant woman so that they know when their child is born they need to get this vaccine on time to protect them from liver cancer ultimately. And then for the village kind of health volunteers or civil society, also kind of using a pregnancy line list, knowing who's pregnant in their community and referring them, giving this kind of line list or registries to the health facility staff and telling them, these are the women who are pregnant in my community. Some of them might be delivering at home. I just want you to be aware. And when they deliver, they could inform the health facility staff and see whether they could bring the vaccine and vaccinate them at home, or they would kind of refer them to go to the health center for vaccination. Many times it's not going to be within 24 hours for the home birth, but even within 3 days, I think that's still effective, and we should still kind of aim for that. So that's kind of some of the outside the cold chain approach you know, it's good to kind of assess that also, whether it would work in a setting, you know, in African countries or not. Some people mentioned Uniject. I mean, I know it has been used in Wipro. The cost was a big burden. So if there's more support for kind of the Uniject injection, you know, in terms of costing, maybe that might be also good to try and see how successful it would be in increasing home birth kind of vaccination coverage. And the other part is also documentation of timely birth dose. We've seen from many of the country reports of coverage, it's quite hard to differentiate what's total birth dose coverage from the timely birth dose. I know particularly from Nigeria, their coverage has been increasing for total, but we don't know what's the percentage of timely birth dose, and that's the most important component. We know the timeliness is very important in prevention of mother-child transmission. So we really need to work on that, documentation, the data, the quality of the data, and the management of the data at the country level is also important, and also reporting at the various levels. Some of the previous assessment post-introduction of birth dose, they clearly showed that there was kind of a gap in how the healthcare workers could calculate the timeliness of the birth dose or not. So there's definitely some training around that area as well. So these are my general observations and comments. So I think there's, you know, there's really nice kind of stories, you know, success stories, as well as challenges from the countries. And we're looking forward to see how we can better support them in improving their vaccination coverage with timely birth dose, as well as introduction in the future.
Thank you, Rania. Other comments, please?
I think one of the other questions that I've seen in the comments is about the use of the vaccine out of cold chain. I don't know whether any of you could respond to that.
Sister, please come.
But the HepB vaccine can be transported and stored outside the cold chain if you have you know, the temperature controls in place to verify that it remains within the range of temperatures where the vaccine remains viable. So it does not need to be stored, you know, in refrigerated compartments over time, as long as it can be kept, you know, within that temperature range, and you can monitor the temperature to assure that it remains viable. And there's a number of different instructions and technologies to help maintain that quality control outside the cold chain. Other comments? Let me just add on to comments from Rania and Antoinette to again thank all of the presentations that were so informative, so clear as to what was the state of the burden of hepatitis, what was the current status of protection for newborns, the strengths and the limitations, and the work that needs to be done to improve prevention. You know, what I hear is that there's broad agreement that more needs to be done to interrupt transmission of this highly prevalent infection among the general population, and that you know, the timely birth dose, you know, is the goal, and how to achieve it is our aim. And with a critical role of the EPI programs, as has already been referenced in terms of policy development, training, supply, distribution, monitoring, and then the critical role of maternal and child health programs to actually deliver that timely vaccination, and how to develop those working collaborations is really critically important. Beginning with in-facility births and then seeking to improve coverage for the more difficult challenges of timely birth dose for home births. You know, for myself, I learned there were key opportunities for integration. For BCG, vaccination, polio, vitamin K, other interventions at the time of birth where this could be applied. As has already been mentioned, the critical role of data to monitor what is actually happening so you can identify areas for quality improvement. The critical role of global partners. We heard mentions of WHO, UNICEF, Gavi, US CDC, MSF, and so we need to keep them engaged. And I think this community of practice that we're building will help bring that about. I know that some of the investigators from our webinar 1 are on the call today, so I really encourage them to stay involved too, because they have a lot of data to share and experiences. As far as the coalition going forward, we will bring together this information. We're not going to change practice greatly with just one webinar. We want this community of practice to elevate all of these issues so that we can help you address them and engage other partners in building the capacity to help with that implementation challenges that you were so clearly laid out for us today. And then we can really begin to see how do we address those together as a community of practice. Also, there were a number of tools and strategies that were mentioned today, both from the US presentation, Botswana, elsewhere. We will seek to collect all those tools and strategies so you can make use of those or ask questions about how they can be used for you as part of this community of practice concept. And as I mentioned, we will be having all the presentations, available, as well as a synthesis report. And then we can use that information to raise awareness of these needs more broadly, to get broader commitments that will help us scale up hepatitis B vaccination for newborns in your country and then for the region. So please stay engaged, in this effort. For our work, the next webinar will be looking at how can we support the NITAG process, and then in the webinar 4, we'll seek to see what really can be done going forward. And again, please follow us along with the next webinar, as well as the webinar number 4 later in the summer. I look forward to working with you all. I don't know if, Lindsay, do we have a evaluation question for a poll?
Yes, I'm trying to see if I can bring it up, having some technical difficulties.
But in any event, well, if we can't bring it up now, we would very much like to learn from you what you got out of this webinar. How can we help improve these information sharing, education opportunities in the future so that they're more helpful for you. But again, let me thank you very, very much for your excellent presentations and information sharing. And we look forward to providing those opportunities for an additional numbers of countries who were in the webinar today, but did not have a full opportunity to present, where they are in the status of their programs. And I'm sure we could learn from you as much as we learned from the presenters today. So I think I'll stop there. Thank you again to everyone, and turn it back over to Henry for final remarks and closing. Henry?
Thank you very much. I think mine is just to thank you all for participating, and not only participating, but also for the discussions that you've had. I think these have gone a long way in terms of giving us all this knowledge that will help us with the process of introducing, as well as improving the coverage for those countries that have introduced the hepatitis B birth dose vaccine. So stay tuned, there'll be more coming. In the next webinar series, like John has mentioned, we'll be talking about NITAGs, inviting them to share their experiences. And we also hope to present a draft toolkit that can help NITAGs in terms of making a recommendation for the hepatitis B birth dose to their respective ministries of health. So stay tuned, and I encourage you all to continue participating in this and reach out to other members, especially who are not represented here, the NITAG officers especially, for the next meeting. And thank you so much, and it was a pleasure working with you all.
Thank you again.
Thank you so much. Thank you so much, all.
Bye-bye.
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 Good.
Bye-bye. Bye-bye. Thank you so much.
Thank you.
Bye-bye. Thank you.
Thank you. Bye-bye.
Thank you.
Bye.
Bye-bye.
Bye-bye. Bye-bye. Thank you.
Thank you so
Bye.
much.
Thank you.
Good. Good.
Thank you.
Thank you.
All the best. Thank you. Thank you, Nicholas.
Thank you. Bye-bye.